Yeah, it's live streamed on YouTube now, so we can start. Bala
Yes.
Venkat sir,
Yeah. Okay. Yeah. Sure.
sir, we can start now.
Yes, Dr. Bajwa.
Yeah, please, sir, please, with your welcome address.
Um, Good evening to everyone. At the outset, I would like to thank Dean Dr. Uma Maheshwar Rao and Associate Dean Dr. Srinivaslu, our National Governing Council member, for taking this initiative of academic sessions through the College of Indian Society of Anesthesiologists. For all those who are logging in for the first time, the College of Indian Society of Anesthesiologists is the academic wing of Indian Society of Anesthesiologists, which has been formed to strengthen academics research, forming guidelines, and make sure that the society actively contributes to academic progress and growth in this country. And thanks to Dr. Mameshwar Rao for taking all the efforts to do the online courses. And today we are very fortunate that we have chosen some very important component that every anesthesiologist should know: the pain. The single most important reason for which a patient would need the help of an anesthesiologist in the perioperative period, in the critical care. And I'm very happy that we have with us Dr. Sri Ganesh Kamath to moderate this session. We welcome you, Dr. Sri Ganesh, on behalf of the National Governing Council of Indian Society of Anesthesiologists. And my warm welcome to all the faculty for this session: Dr. Vinita from KIMS Trivandrum, Dr. Nikita Goel from PGIMR Chandigarh, Dr. Neha Kanodia from Continental Hospital Hyderabad, Dr. Jishnu Tople from Nagpur, Dr. Rajendra Sahu from KIMS Bhubaneswar, and Dr. Amitesh Patek from Lucknow. We sincerely welcome all of you and all the delegates and senior members of ISA who are part of this session, and I'm sure this next 3 hours will transform our understanding and conceptualization of pain and pain management. A warm welcome to all of you. Over to Honorary Secretary Dr. Sukhmandirjit Singh Bajwa.
Thank you, sir, for your such a nice warm welcome to everyone. Before we proceed, I first of all like everyone to mute themselves and pray for 1 minute in the memory of father of Dr. Srinivaslu Damoda. Amen. Now I think our activities of CISA are going great guns. It has got multiple directions, right from the webinars to the courses to the books. And in the coming conference at Raipur, we will be bestowing the first fellowships of CISA. And thereafter, I think the wings are already growing and we will take off from Raipur onwards. So all are welcome to the ISACON Raipur because it will going to be one of the very good conference for a years to remember. I must admit that Dr. Uma Rao sir, as Dr. Bala said, he has a immense energy. He may be retired, but he's not tired. He has got energy. Today I was busy in the meeting. Sir called 6 times because I was meeting, and after the meeting I had to tell that everything work is being done. So that's also not shows the energy, but also the commitment to the cause. And Dr. Srinivaslu, our GC member, is good, equally well efficient in working as associate dean in this College of ISA. And most importantly, the entire GC, even including Dr. Ashish Diwan, also present here, and other members will be joining in. Everybody is very upbeat about the functioning of the College of ISA. And for information of everyone, the College of ISA will be celebrating the Anesthesia Action Week from 10th October to 16th October. The program we will be giving you very soon, mainly the academic programs and all the future projects which are going to be launched during those 7 days. And with the help of cooperation of Dr. Bala Venkat sir, we are going to invite ASA people, WFSA people, Europeans, so many people will be participant to our Anesthesia Action Week, which is observed only in the country of India. Nowhere else Action Week can be celebrated. But I think we have a global copyright for that function, sir. Bala sir. And I think that's the right way to go move forward in the academics, paralleling the academics of the global societies. So without wasting much time, I hand over it to our Associate Dean of the college, Dr. Srinivas Damur, who will take it with the Dean and the present faculty, whom already have been welcomed by Bala Venkat sir.
Yeah,
Dr. Srinivas sir.
yeah. Thank you, sir. First of all, I would like to thank the administration of ISA National and College of ISA, including our ISA National President, Dr. Bala Venkat Subramanian, sir, who is also Chancellor of College of ISA, Dr. J.V. Divetia, sir, who is Vice Chancellor of College of ISA and Academic Chief of ISA National, and our dynamic secretary, Dr. Sukhminderjit Singh Bajwa, who is also academic secretary of College of ISA, and our administrative secretary, Dr. Bharat Bhushan Bharadwaj, for giving us this opportunity and for all logistical support. This is the fourth program from College of ISA webinar wing. And again, I welcome you all. And over to Dr. Uma sir for his opening remarks and next proceedings.
Sir, unmute yourself. Uma sir, unmute yourself.
Uma sir, unmute. Yeah.
Yeah, am I able to hear? Are you able to hear me? Yeah. Yeah. Good evening, everybody. So, as anesthesiologists, our primary responsibility is to relieve pain. So, today we have a wonderful symposium on pain, which is being coordinated by Dr. Sri Ganesh. Dr. Sri Ganesh is the head of the Department of neuroanesthesia and neurocritical care for the last 3 years. And during his tenure, he encouraged the culture of research in neuroanesthesia. He brought 7 crore funding for the research. And he did his MD from JNMC Belgaum. Then after that, he did his BM in neuroanesthesia from Sri Chitra Tirunal Institute of Medical Sciences. And then he joined NIMHANS and he worked for more than nearly 10 years now, more than 10 years. And he has 2 fellowships in pain. He worked extensively in pain. He is running the pain clinic in NIMHANS for the last nearly 10 years. And he has 2 fellowships, one from India and one from Canada, Hamilton. He worked 6 months exclusively on pain in Hamilton, and he is ably assisted by Dr. Vinita, Dr. Nitika Goyal, Dr. Neha Kanojia, Dr. Jeshnu Topal, Dr. Rajendra Sahu, Dr. Amitesh Patel in this symposium. I request Dr. Sri Ganesh to start the symposium.
Thank you, sir.
Yeah.
At the outset, I thank the ISA and CISA leadership for this opportunity, and I express my gratitude to all the speakers who have agreed to be the resource persons for this pain school of 3 hours for this program, and who will be enlightening us all on the various aspects of acute and chronic pain, both starting with the pain pathways, assessment, and assessment and management. And I'm sure that it will be of use to all the participants who have logged in, both the postgraduates, the practitioners, and also the consultants as well. So let's begin the session. I request the first speaker to kindly share the slide. Meanwhile, I'll introduce Dr. Vinita Gopal. She is consultant in pain medicine in Trivandrum, working for 3 franchises, KIMS Health, Rumacare, and Pallium India. She completed her MD in anesthesiology from GMC Thrissur and fellowship in pain medicine from SGPGI Lucknow. She is also an FIPP, the fellow in interventional pain practice from USA. Her areas of interest include spine intervention, musculoskeletal ultrasound and intervention, neuropathic pain, regenerative medicine, and cancer pain. Dr. Vinita.
Good evening, sir. Am I audible and are my slides visible?
Yes.
Okay. So first of all, I take this opportunity to thank the College of Indian Society of Anesthesiologists for giving me this opportunity to talk on this very important topic. Good evening, all the respected seniors, teachers, and colleagues. So my topic for today is a very basic, at the same time a very complex and difficult to understand topic. That is a pain physiology and pathophysiology. So without much delay, we'll go into the topic. So as an introduction, what is pain? So pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. We all know this is the definition of pain by the International Association for the Study of Pain. But we don't need such a big definition to understand what is pain. In simple terms, pain is what the patient says it hurts. So after this 3 hours webinar on pain, I think one of the most important messages one should take home, be it in the acute perioperative setting or in the chronic pain setting, you should believe the patient, because pain is what the patient says that hurts. Now, pain is classified into acute pain and chronic pain. I think most of you know this. Less than 3 months is usually considered as acute and more than 3 months chronic. And another classification based on the character and the pathology is into nociceptive, neuropathic, and nociplastic pain. Nociceptive pain is when the tissue nociceptors are activated following an injury, then we get the nociceptive pain. Neuropathic pain is defined as a lesion or disease of the nervous system itself. And nociplastic pain is a new term coined by IASP, for the pain in which there is no identifiable peripheral pathology, but it's more of a sensitization, central sensitization, like fibromyalgia and many other conditions. They are now classified under this nociplastic pain. So now going to my topic proper, that is physiology and pathophysiology. I'll be dealing with the pain pathways and the normal physiology and the pathogenesis of chronic pain. As I mentioned before, it's a very difficult topic to understand. At least for me, I have always felt like that. So in 25 minutes to cover the entire pathophysiology is difficult, but I'll try as much as possible. Now, first of all, is physiology and pathophysiology important? What do you think? It is important for 2 reasons. One reason is that for the postgraduates here, it is an essay question. For 10 years back, for my MD exam also, this was an essay question, this pain physiology and pathophysiology. Another important reason is like this. If we manage a patient with pain, considering only the symptomatology or the imaging findings, very likely we will miss the big picture. So we should know, we should have a clear idea of what is happening inside. So coming to the pain pathways. So in the simplest form, These are the 4 steps. So the story starts in the periphery. First, there is a nauseous stimuli. This stimuli is converted into an electrical action potential, that is known as transduction. Then this action potential is transmitted along the neurons to the spinal cord and then to the thalamus and to the cortex, that is known as transmission. Then we have modulation. Perhaps the most important word in my class is modulation. I'll come to that in detail later. And then after that, the perception in the cortex. So these are the 4 steps of pain pathway. Now, there are ascending pain pathways and descending pain pathway. So the ascending pain pathway, we have one pathway that deals with the sensory discriminative component. That is the nature of pain, the location of pain, the severity of pain. So all these are carried through the spinothalamic tract or the lateral pain pathway. It's also known as the lateral pain pathway. Then we have another pathway that carries or that is responsible for the emotional affective component, the emotions associated, learning, memory, etc. Then the autonomic responses associated with pain and the modulation of pain. So these pathways includes the spino-reticular pathways, spino-limbic pathways. These are essentially from the dorsal horn of spinal cord to the reticular formation of the brainstem or to the limbic system. And these pathways are together known as medial pain pathways. So in short, lateral pain pathway deals with the discriminative component like location, nature, severity, and the medial pain pathways deal with the emotional component, autonomic responses, and modulation of pain. I hope that is clear. Now, so this is the most important, the pain pathway, that is our lateral pain pathway or the spinothalamic tract. So again, the story starts here in the periphery. So the first order neuron, it is located in the dorsal root ganglion. And these neurons are known as pseudo-unipolar neurons because they have 2 types of axonal projections. The one axonal projection comes to the periphery. I hope my cursor is visible. So the first axonal projection comes to the periphery, and these projections have free nerve endings known as the nociceptors. These are the nociceptors. So the A delta and C fibers, their free nerve endings are the nociceptors. Now, from the dorsal root ganglion, the second axonal projection of the same neuron, it goes to the spinal cord and it synapses in the dorsal horn of spinal cord. Now, if you look at the dorsal horn of spinal cord, it has got laminations from laminae 1 to 10. Actually, there are laminations from superficial to deep 1 to 10. Out of this 1 to 6 deal with pain. Again, out of this 1 and 2 are densely innervated by the cutaneous A delta and C fibers. Now, what happens to this A delta and C fibers in this dorsal horn? There are 2 possibilities. One is that they can synapse with the second order neuron or known as the projection neurons here, or they can synapse with the interneurons. Also, they don't synapse here. They may travel a few segments up and down and synapse in the dorsal column there. Right? Dorsal horn, not dorsal column, dorsal horn there. Now, after the synapse, so we should know that this cutaneous, I'll come to that in the next slide, cutaneous A delta and C fibers, they synapse in the superficial lamina, whereas the visceral fibers, they go into the deeper lamina. Now, after the synapse, this projection neurons, they cross to the opposite side and then they ascend as the lateral spinothalamic tract and they reach the thalamus where they synapse with the ventro-posterolateral nucleus of thalamus, the VPL, and from there projections go into the sensory cortex S1 and S2. So this is the spinothalamic tract. Now, so this is the difference between how the cutaneous fibers terminate and the visceral fibers terminate. The cutaneous fibers, they terminate in the superficial lamina 1 and 2. They may ascend or descend 1 or 2 segments before they synapse. So essentially, these terminations are very focal, very localized terminations. Whereas the visceral fibers, they synapse in the deeper laminae. they ascend or descend multiple segments, more than 5 segments up and down before synapse, and they may even synapse with the contralateral dorsal horn neurons. So what happens? They have diffuse or widespread synaptic termination. So this is the physiology behind why the musculoskeletal pain, the somatic pain is very localized, that is very localized, and the visceral pain is often referred to as poorly localized, dull aching, vague pain or vague discomfort. And if it is the liver is involved, we need not always feel pain in the right side. We often have a diffuse abdominal pain. So that is the reason behind this visceral nociceptive fibers, how they terminate. Okay. Now, apart from this spinothalamic tract, which is shown as the red, I have already told there is another ascending pain pathway, which is a medial pain pathway, which is concerned with, as I told, this effective component, autonomic response, modulation. So that is shown in green here, this medial pain pathway. So what is different here is they give a lot of collateral inputs to the reticular formation in the brainstem, midbrain, and then they reach and synapse the VPM, not VPL, the ventroposteromedial nucleus of thalamus. And from there, the projections go not into the sensory cortex, but into the cingulate cortex, prefrontal cortex, the insula, etc. So that is the difference why they are concerned with the emotional component, autonomic response, etc., and not with the discriminative component. So that is about the spinothalamic tract or the lateral pain pathway and the medial pain pathway or the spino-reticular tract. Now the descending pathways, the descending pain pathways can be excitatory or inhibitory pathways. But more important is the inhibitory pathway, descending inhibitory pathway. But I'm not going into detail here because I'll be taking that along with the modulation. So we just need to know that at this point of time, there are descending pathways from the brain to the spinal cord that has a role in modulation. Now, so coming to that second part of my topic, the modulation of pain and the pathogenesis of chronic pain. So there can be two types of modulation. One is the excitatory modulation or sensitization, that when the pain, the acute pain, be the perioperative pain or any acute pain, is left inadequately treated for some time, this is the most likely outcome. Okay. The excitatory modulation or sensitization, that is over the time, the pain gets amplified. Then there is another type of modulation known as the inhibitory modulation also. In this case, if we are treating the pain properly, over time the pain becomes much better. That is in simple terms, excitatory modulation and inhibitory modulation. Now, excitatory modulation or sensitization, this is a very difficult to understand topic, like how this happens at the molecular level, so many names, genes, channels, but I'll try to keep it as simple as possible, especially for the postgraduates to understand. So the sensitization can be divided into two. It is peripheral sensitization or the central sensitization. Now first we'll deal with what is happening in the periphery at the tissue level. So look at this picture. So now there is a tissue injury. So when there is a tissue injury, what happens is there will be cellular disruption, there will be loss of vascular integrity, increased permeability, there will be extravasation of plasma, and these cells like mast cells, neutrophils, macrophages get activated. When these cells get activated, they release all these neurotransmitters like histamine, ATP, bradykinin, prostaglandins. Apart from that, in the setting of a tissue injury, this is the primary afferent neuron, our C fiber. This primary afferent neuron itself will release something like substance P and CGRP, which will further activate these cells. So now here we have lot of inflammatory mediators, and this is known as inflammatory soup. Okay. Now the result of this inflammatory soup is that a lot of changes in the the ionic conductance, like increased sodium conductance, decreased potassium conductance, etc., happens in this primary afferent neuron, and the net result is that these primary afferent neurons, our A delta C fibers, they become hyperexcitable. Okay, increased excitability. So what does that mean, this increased excitability? There is a lower threshold for stimulation, that they get stimulated very easily, and for any given stimulus, there is increased response. Okay. And in the setting of nerve injury, another thing also happens, that is spontaneous activity. That is, without any stimuli itself, the nerve will fire. That usually happens in the setting of a nerve injury. Otherwise, peripheral sensitization means what happens is increased excitability of the primary afferent neuron, the C fiber, such that for any given stimulus, there is an exaggerated response. And what does this lead to? This lead to what is known as primary hyperalgesia. That is, in the injury site or the primary site of the pathology, when you give a nauseous stimuli, there is exaggerated response. That is known as primary hyperalgesia. Now, how we can block this? I told that prostaglandins is one of the important components of this inflammatory soup. So we can block that using NSAIDs. And here, this increased action potentials, they are transmitted through the nerve fiber. So we can block this using our local anesthetics, that is regional blocks. That is why in the perioperative setting or in the chronic pain setting, it's very, very important to supplement our GA or supplement other drugs with regional anesthesia or blocks, because it has a direct role in preventing the peripheral sensitization from happening. Now coming to the central sensitization. So here, look at the dorsal horn. So can you please unmute? Okay. So here, central sensitization takes place at the dorsal horn level. So we can see how this happens. So this is the dorsal horn. This is our primary afferent C fiber, and this is our second order neuron, the projection neuron in the dorsal column of the spinal cord. These are the neurotransmitters. What does this C fiber usually release? They release glutamate. Okay, sometimes substance P also. Now this glutamate usually acts on this particular receptor, which is known as AMPA, this AMPA receptor. And the sodium conductance is increased and an action potential is generated. Similarly, substance P can act on this NK1, neurokinin 1, and an action potential is generated. This is what happens usually. But in the event of persistent, firing from the periphery, we are not treating the acute pain properly. There is a lot of stimuli coming from the periphery. What happens is, so before that, this receptor, the notorious receptor behind central sensitization is the NMDA receptor. This NMDA receptor is usually blocked by magnesium. But in the event of persistent firing from the periphery, this magnesium gets unblocked. This receptor gets unblocked. Magnesium goes away. So what happens is, now this glutamate, apart from binding to AMPA, will now bind to NMDA. What happens after that is, you can see here. Once the glutamate binds to the NMDA, lot of calcium comes inside. And this calcium will activate a lot of enzymes, one of the most important enzyme being this phospholipase A2. Phospholipase A2 will break the membrane phospholipids and form the arachidonic acid. And this COX enzymes, they work on this arachidonic acid and prostaglandins are formed. The net result is that prostaglandins are formed. These prostaglandins, they act on the presynaptic C fiber receptor as well as the postsynaptic, this projection neuron receptor. What will the prostaglandin do? Once the prostaglandin binds to this prostaglandin receptor, here you can see one receptor presynaptically. This receptor is a voltage sensitive calcium channel. Here also you can see. This is the primary afferent neuron, and there is one receptor here which is a voltage sensitive calcium channel. So once the prostaglandin comes inside, due to the ionic changes, this voltage sensitive calcium channels open up and lot of calcium comes inside, and this calcium will cause more neurotransmitter to release. All these neurotransmitters will again go and work on our NMDA, and this cycle continues. The same thing happens here with nitric oxide also, same with prostaglandin. So the net effect is that for any given stimulus, there is increased output from the dorsal horn neurons. So this is known as the central sensitization. Now, how we can prevent this from happening? First of all, here, I told NMDA is the culprit. So how we can block the NMDA receptors? Using ketamine or drugs like methadone, like that. Okay. The next target is this. In the presynaptic C fiber, we have the voltage sensitive calcium channels. Okay. So voltage sensitive calcium channels, which drug acts on this? This drug has got a alpha-2 delta subunit, and our gabapentinoids like pregabalin, gabapentin act on this voltage sensitive calcium channels. So that is the role of gabapentinoids in desensitization. I regularly use gabapentinoids for chronic pain with lot of sensitization. So the evidence may vary, but this is a basic mechanism behind the use of physiology behind the use of this gabapentinoids. Then the next is here, the action potential. How can we block this action potential? Because sodium conductance increases, and that is when the action potentials are generated. So we can use sodium channel blockers like lignocaine, local anesthetics, and oscarmazepine. Then again here, I told the main reason is when this calcium binds to NMDA, lot of enzymes are activated, mainly phospholipase A2. With the help of COX enzyme, the prostaglandins are generated. So how we can block this using NSAIDs? So these are some of the drugs that helps us in tackling or preventing central sensitivities. Now, we have just a word about this wide dynamic range neurons, WDR neurons, because these WDR neurons basically is a type of a projection neuron seen in lamina 1 and 5. But the difference is that they respond to a wide range of stimuli, not just pain, from light touch to sharp pain, a wide range of stimuli, and they have got a wide receptive field. They receive information from a large area of the body. So because of these two reasons, they have a very important role in the development and maintenance of chronic pain or sensitization. Now, this is again the same picture of sensitization, central sensitization. This is a WDR neuron. This is just another projection neuron. And here we have the C fiber, the primary afferent neuron. The idea of this picture is, apart from what is happening between the C fiber and the projection neuron, which I already explained, there are some other mechanisms that help in central sensitization. One is through interneurons. In the dorsal horn, apart from the projection neurons, we have inhibitory as well as excitatory interneurons. So in the setting of sensitization, this inhibitory interneurons that work through GABA and glycine neurotransmitter, they also become excitatory. That is loss of inhibition provided by the inhibitory interneurons. Then we have non-neuronal cells like glia, microglia, astrocytes. They also release the stored neurotransmitters. Then we have descending excitatory pathways like bulbospinal pathways. Altogether, this contributes to the central sensitization. And this is known as the neuroplasticity and wind-up phenomenon, the temporal summation of pain. And just to complete that, the gate control theory of pain proposed by Melsack and Wall in 1965, because I was talking about inhibitory interneurons. So when normally when the C fiber synapses with the projection neurons, this is the gate. The impulse is transmitted to the brain. But when the large diameter A beta fibers, the touch fibers, are activated, they work through this inhibitory interneurons and inhibit the synapse here. Okay. So this gate is closed. That is the physiology behind the use of TENS, even spinal cord stimulation. All this work on this gate control theory of pain, and it is basically mediated through this A beta fibers and inhibitory interneurons. So this is a net result of the central sensitization. There is increased excitability of the projection neurons. After peripheral sensitization, there was increased the excitability of the primary afferent neurons. But now the dorsal horn neurons, they are hyperexcitable. For any given stimulus, there is an increased response. And also, it increases the receptive field of projection neurons. For example, the pain is coming from this particular area. The dorsal horn neurons that corresponds to only this particular segment will get activated usually. But in the event of sensitization, the other segmental dorsal horn neurons also will get activated. So that is why the area of pain increases with the duration of pain. And if we are poorly treating pain, the area of pain, not just the severity of pain, the area of pain also increases. That is due to this particular action, that the sensitization increases the receptive field of projection neurons. So that these are the net results. We can whatever I have told, the increased intensity of pain, increased area of pain, increased duration of pain, decreased tolerability to pain, development of psychological problems, and the pain becomes non-responsive to conventional analgesics. And just a word about what extra happens in the nerve injury and the sequelae. In case of a nerve injury, when the axons regenerate, sprouting occurs. And the collection of sprouts is known as neuromas. And these neuromas, as well as the DRG of the injured nerve, becomes hyperexcitable. And this hyperexcitability causes, as I told before, exaggerated response to any given stimuli, low threshold for stimulation, and spontaneous or ectopic activity. That is why in the setting of nerve injury, apart from severe pain, there will be ectopic discharge also. Apart from increased excitability, there will be spontaneous activity also. Another thing is, during this axonal regeneration, the sprouting of sympathetic fibers to somatosensory fibers occur. And this phenomenon is known as somatosensory coupling. So sympathetic activation results in activation of the sensory fibers also. And this is the reason behind the development of the sympathetic mediated, one of the reasons behind the development of sympathetic mediated pain in neuropathic pain, CRPS, and why we are giving sympathetic blocks for treating such pain conditions. That is because of this abnormal sprouting of sympathetic fibers to somatic sensory fibers, resulting in somatosensory coupling. And another thing that happens is, when this axon regenerates, some crosstalks or abnormal connections between the A, beta, and C fibers happens. And also there is synaptic reorganization. A beta fibers usually synapse in the deeper lamina, but in the event of sensitization or nerve injury, it synapses in the superficial lamina. And because of these two reasons, when A beta fibers are activated, touch fibers are activated, then also we feel pain. So that is a reason for allodynia in the setting of a neuropathic pain or nerve injury. And the inhibitory modulation it can happen in the dorsal horn as well as in the supraspinal level. This is I think the last important slide. It's not very important. I think I'll take another 2-3 minutes. So this is a descending inhibitory pathway. So we get, so the story starts here mainly here in the periaqueductal gray of the midbrain. So from the periaqueductal gray of the midbrain and the locus coeruleus of Pons, so many noradrenergic neurons are coming down. And these noradrenergic neurons, they synapse with the dorsal horn neurons and causes inhibition of the pain pathway. So this is the exact opposite of sensitization, causes inhibition. So how can modulate this? So one is, this noradrenaline acts on this alpha-2 receptors causing inhibition. So noradrenaline reuptake inhibiting drugs like tramadol has better action on the inhibition of pain. Also, we can give alpha-2 agonists like clonidine have got better action on the inhibition of pain. So this is the importance of the descending inhibitory pathway. And finally, the pain and the brain. So this is a very controversial statement, and I found this in this particular article. But they say that as the pain goes on untreated, becomes more and more chronic, there is a gray matter volume reduction. This is there in so many articles, but what is controversial is they say almost 1.3 centimeter cube decrease in volume per year. So I'm not sure about this volume, but one thing is sure, there are so many studies that point that there is definitely significant reduction in gray matter volume, and the chronic pain patients reach somewhat a dementia or Alzheimer's state much earlier, or a lot of cognitive behavioral problems and decreased memory because of this chronic pain and the changes that happen in the brain. Okay. And the take-home message is being, we have to believe the patient. Sensitization results in primary hyperalgesia, secondary hyperalgesia. In the setting of nerve injury, there are other things that are happening. The ectopic discharges, somatosensory coupling, and the crosstalks with A beta and synaptic reorganization causing allodynia. And the net effect of sensitization is the pain increases in area, severity, and evolves into a complex chronic pain condition that is extremely challenging to treat. And once it becomes chronic pain, we know what are the problems. It is not just a physical problem. A lot of psychological issues, financial burden, social isolation, the quality of life is reduced to a severe extent. So it's important, our motto should be treat early and treat well. And I also take this opportunity to invite you all to our 6th annual conference of the Kerala Society for the Study of Pain, November 8 and 9. We have cadaveric fluoroscopic workshop as well as volunteer-based ultrasound workshop. I invite you all. Apart from the academic fiesta, you can also visit the Adirapalli Falls where Bahubali was shot. Thank you.
Thank you, Dr. Vinita, for very lucid presentation, making it very simple to understand for the postgraduates and occasional pain practitioners. Thank you for that, and also highlighting some of the potential targets in the pain pathways and molecular mechanisms where pharmacological interventions may be of use in both preventing and as well as treating pain. Thank you.
Yes.
We move on to the second presentation. I request Dr. Vinita to, please. We move on to the second presentation, and that is on the assessment of acute and chronic pain using subjective and objective methods. This talk will be delivered by Dr. Nitika Goyal, who is an additional professor at the PGIMR Chandigarh. She has recently completed her fellowship in pain medicine from All India Institute, New Delhi. Her areas of interest include ultrasound-guided, minimally invasive pain and spine interventions and chronic pain management. She has got few awards and has published in the area of pain as well. I invite Dr. Nitika Goyal to make the presentation. Thank you.
A very good evening to all of you. First of all, I would like to thank the ISA team and the CISA team for giving me the opportunity to present this important topic here, assessment of acute and chronic pain. I hope I am audible.
Yes.
So as has already been discussed in the previous slide, pain is defined as an unpleasant, sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage.
has joined the meeting.
Pain is a subjective, multidimensional experience influenced by many factors in addition to the psychological component. It has psychosocial factors associated with previous emotional experiences, cultural and environmental influences, and emotional states such as depression.
Rajendran has joined the meeting.
As has already been described in the previous presentation, pain has been defined into acute, subacute, and chronic pain. Acute is any pain which is lasting for less than 6 weeks.
To everyone.
Subacute is pain lasting for 6 to 12 weeks. And chronic pain is any pain lasting for more than 12 weeks.
Abraham has left the meeting. iPhone has left the
chronic
meeting.
pain has been divided into seven groups, which include the chronic primary pain, chronic cancer pain, chronic post-traumatic and post-surgical pain,
left the meeting.
chronic neuropathic pain, chronic headache and orofacial pain, chronic visceral pain, and chronic musculoskeletal pain.
To everyone.
The purpose of pain assessment includes determining its nature, severity, and degree,
Press CMD
helping in the diagnosis,
pop-up.
helping
Sneha
to
Abraham
choose the
has joined
appropriate
the
treatment
meeting.
method,
Dr.
and
Gurunath
evaluating the
Treti Begun
efficiency
has
of
left the meeting.
the treatment
Absent
strategy.
To
Excuse me,
everyone.
ma'am.
There is
There is
disturbance.
noise behind.
Sarat has joined the meeting. Your companion has been turned off. Close. Press CMD plus tilde to open pop-up.
Ma'am, we are getting disturbance from your cell. When anyone joins and leaves, that is adding voice message is coming.
Okay, sorry, ma'am.
Yeah, I think it has stopped now. I think we can continue.
Okay. So while doing the assessment of pain, it is important that we look at the sensory experience, assess for the presence of any cognitive experience and affective experience, and the presence of any autonomic activation. So I'll be basically dealing with all the assessment of these in my coming slides. The role of pain assessment is to sort out the different contributors to each dimension and the relative importance in affecting the functional impact of pain in each individual. So there are multiple strategies for the assessment of pain, which include interviews, standardized questionnaires, diaries, behavioral observations, psychophysiological evaluation, and assessment of family members, which is important to quantify the pain experience. The assessment of pain can be divided into subjective and objective assessment. So,
TV to everyone.
Firstly, in the subjective assessment starting with the pain history, the medical and
Dr.
surgical
Dr.
history.
Nitika,
Taroya has
just-
left the meeting.
do you have one more
Dr.
device which is
joined the
logged in?
meeting.
Sir,
Because
it's my
coming
own
from
MacBook.
your source.
Please check the settings, ma'am, that when everyone leaves and joins, it's giving message.
Giving the message, yeah.
Audible
Okay.
message, yeah. I think
Please
yours-
check your settings once, ma'am.
I think somebody has also opened two
devices.
devices. That is why it is coming again and again. Or I will do one thing, I will mute everyone. Dr. Nitika, you unmute after that, huh?
Okay,
Yeah.
right, sir. So
Yes.
can you just tell me when to start my presentation again?
Yeah, yeah.
Now you can unmute yourself. I muted all.
Right, sir. So the subjective assessment of pain includes the pain history, the medical and surgical history, ruling out the red signals, the psychosocial presence of any psychosocial comorbidities, the sleep disturbances, the cognitive impairments, any vocational history, any presence of any current disability due to pain, the habits, the any previous medications including opioids, abuse or dependence, the physical functionality of the patient, the current and past treatments and the medications the patient has taken, any presence of allergies, and assessment of the previous investigations and consultations. So the history taking can be divided into the mnemonic, that is the Socrates, which we commonly use here while taking the history. The S stands for the site, where exactly the pain has started, and the maximal site of the pain, the onset of the pain. When did it start? Did it start suddenly, or was it gradual in onset? And has it increased progressively or decreased over time? The character of pain. What is the character exactly? Is it stabbing or burning type of pain? Does it radiate anywhere? Is it associated with any signs or symptoms? The time course, does it follow any particular pattern? The exacerbating and the relieving factors, and what is the severity? How intense is the pain? So we have to assess how it started. Did it start suddenly, like in the pains of subarachnoid hemorrhage? Like they usually start suddenly.
And left the meeting.
Did it start on a severe, like the presence of the severe pre-existing pain, like spinal mets,
iPhone to everyone,
and the site of onset of the pain, the trauma in the was it present in the past?
has left the meeting.
Then the severity of the pain. So severity is assessed usually by using certain scales. These are the subjective experience.
has left the
The current pain
Dr.
intensity
Nitika, sorry to interrupt you.
To everyone, so much disturbance.
I think your device is the source.
CMD plus Tajana to everyone, phone is reading the screen. Settings to be
I
changed.
think you have to mute your AI
has left the
option.
Somebody has started the YouTube streaming also simultaneously, I think. That's happening.
just
You share the screen again now.
I think when you're speaking, it is also getting captured.
has joined the meeting. You have started screen share. Ayushi Singhal has left the
yes,
meeting.
sir. It is actually starting with my screen share.
Join the meeting.
I think you need to mute your. There must be some AI message on your screen. You need to mute that.
Sir, I just checked. There is no.
Motorola Edge 15U has joined the meeting. Dr. Esplavin has left the meeting. Ritu's iPhone has left the meeting. Dr. Esplavin has joined the meeting.
People, I think all the messages are being read from one screen.
I think it's her screen, sir. From her device, this.
Dr. Harpreet Kaur to everyone. There's iCompanion on his screen that you need to switch off. Mohammed Shafi has left the meeting. Has left the meeting.
Sir, I'll just try again to
Nishant Sahaya to everyone. Can you PLS stop sharing, and when you start sharing PLS and check the share with sounds box, it may help.
I muted everyone again. Now I think only speaker should unmute.
Shika has left the meeting. Dr. Harpreet Kaur to everyone. Kindly switch off the eye companion mode. Sampatya to everyone. Mom, please go into meeting settings in Zoom app.
I think only your screen was non-muted, Dr. Nitika. Rest all were muted. Sir, it's coming.
Yes, sir. So I'm going into meeting settings and just. I've switched on the internal speakers, Microsoft Teams.
I think it's working now.
So I'll continue, sir.
Yeah.
You have started screen share.
No, there is some problem with your source.
Dr. Basu sir, just I have sent you one just screenshot. It is telling sign into the Zoom web portal, go to account management, account settings, click on meeting tab. Then under the meeting basic, find and toggle off the sound notification when someone joins or leaves option. It's coming as that. Just check, sir.
Account management, no? Let me see here.
Yes,
I don't want to disturb the webinar in between. Just
yeah,
give me
yeah.
3-4 minutes.
Okay, sir. Okay.
Almost everything is in fine here.
Yeah.
No, I think the problem is with Dr. Nitika. Maybe.
You have started screen share.
Yeah, it's still coming.
I've checked the settings. Settings are fine here. Because this is so. Let me go to the AI companion setting. Just let me see what can I do.
Yeah.
Otherwise, I can share
Everyone,
her, but
go to
voice will be the same
accessibility
problem.
settings on phone. Turn of talkback. Brainkiss iPhone has left the meeting. Johanara has left the meeting. Ayushi Singhal has left the meeting.
I think now we have switched off, Dr. Nitika.
Sir, I've switched off some things, but it's still coming.
No, we are not hearing any.
Yeah, try it now, Dr. Nitika. Try it now.
Okay. Okay.
You have started screen share. Dr. Sontayu has joined the meeting. Dr. Narottam has joined the meeting. Shobhit TV to everyone in your device.
there is one suggestion to switch off the voice assistant from your device. Sir, can we move on to the next speaker till she
Yeah.
gets this right? Otherwise,
We can just let's see. Even I'm also seeing that how can we stop this disturbance.
It's not showing anything to unmute on my side, sir. The AI modality also I checked, that was also not here. It's not showing.
Few are leaving the meeting, but that message we are not getting now. I think it would have solved.
I think it's fine now.
Okay, sir, I'll continue then.
Sir Robert's iPhone has joined the meeting.
It's to start soon when.
I think
Victoria has joined the meeting.
I think it is with Dr. Nikita's thing.
do you have any other device from where you can?
Jana, to me, what device are you using?
I'm using this MacBook Air.
Is there some voice assistance in that which you need to switch off?
There is voiceover, but I don't know how it is. It's inbuilt in my laptop, I guess, because it's not showing in the Zoom, sir. I'm not able to switch it off in the Zoom.
No, it should be done in the device, not on the Zoom.
iPhone has left the meeting.
Okay.
Sir Robert's iPhone has left the meeting.
Can you give me just 2-3 minutes? I'll just then
Dr. Birju
stop
has
my
left the
screen
meeting.
share and I'll try to switch it off in my device then.
Yeah.
Santosh SM has left the meeting. Star 83 Karuna has left the meeting. Ilan Gorganesan to everyone. Ma'am use command in F5. Ajay Balwik has joined the meeting. Dr. Harish Nayak has joined the meeting. Vivek Nayak to everyone. PLS switch off all notifications from that device. Ilan Gorganesan to everyone to switch off voiceover. Menu bar Saji to everyone. Let's try the next speaker and voiceover can try all. Nidana Seem's iPhone has left the meeting. Mabram has left the meeting. Dr. Dharmaraja has left the meeting. Mamia Gupta has joined the meeting. Sajana to me, mute yourself so that we can work on your device. Dr. Geetanjali has joined the meeting. Motorola Edge 15 years left the meeting. Purnender Babu CH has joined the meeting. Sreedman has left the meeting. iPhone has joined the meeting.
Can we go with the next speaker and check
Has
that?
left the meeting.
So by
Dr.
that time,
Sunil has joined the
hopefully
meeting.
this will get
S.
corrected.
Vishwakseen Reddy, Jeshman, to everyone. Mom, it's because of screen share. Dr. Sumita Sharma has left the meeting.
I think better try with the next speaker first now because it's not getting solved.
Dr. Nitika?
Is always a pain. Kishori.
Yeah, I think we'll move on to the next speaker. Is that okay, sir?
Yeah, I think better.
Okay. So the next speaker, next topic that we have is post-operative pain management with specific focus on regional techniques, mainly for the postgraduates. And this will be delivered by Dr. Neha Kanojia. I request Dr. Neha to please share the screen. Dr. Neha is FIPM EDRA and she has a fellowship in chronic pain from University of Toronto, and she is currently consultant in pain medicine, Continental Hospital, Hyderabad. And her areas of interest include ultrasound guided interventions for both acute and chronic pain, advanced pain interventions, neuromodulation, spinal cord stimulation, and peripheral nerve stimulation, and regenerative medicine. She has received scholarships from WFSA and NYSSA in New York. And I now request Dr. Neha.
Yes, I'm trying.
Yeah, you can share your screen.
Share my screen.
Meanwhile, Dr. Nitika, you can go to some of the chat messages where they have given some suggestions. I'm sure some of them definitely would be of use to you to
Yes, sir. I'm just looking.
address that. Yeah,
Yes,
and
sir.
we'll come back to you after this.
Yes.
Neha, you can share your screen.
Yeah, sir, I'm trying to share.
AI is
Sir,
supposed to be of help to us, but AI
yeah.
is causing problems.
So, sir, maybe I should use this the audio button in my MacBook because the desktop one was not working and I can share from the desktop.
You have one more device which needs to be added as a co-host.
Yes,
Okay. Bajwa sir.
I will do it. I'm already logged in.
Okay.
Why is not functioning there?
Yeah, the audio was not functioning.
Now it's, your voice is coming clearly.
We can hear
No,
you.
the desktop one was not functioning.
Okay, desktop. Dr. Srinivas, next time what we do, we
Yes, sir.
make combined presentations of everyone so that it become easy for us to scroll through and time
Yes.
saving also.
Yeah. Yes. Now I think she's able to share the screen.
Yeah, am my screen is visible?
Yes.
Yeah, so thank you, the organizers, and thank you, seniors, for giving me this opportunity. And my talk is on the post-operative pain management with focus on the regional anesthesia techniques. Sorry. So most of the
Neha, we
patients.
can't see your
Screen. We can see your screen. We cannot see your slides.
we can see the downloads.
Uh-huh.
Yeah.
Can you click on that, double click on that so that
But to me, it is visible and they are coming. Maybe just go little escape. But the first slide came?
No.
no. We can see only your download
You
section.
minimize all the other screens.
Other screens, okay.
Yeah, all the other screens you minimize and keep the only
Okay.
the slide presentation thing.
The next time, Dr. Srinivas, do have a technical run also before the webinar. That will precisely help in getting the things
Yeah, I
done
think
smoothly.
we did through
1 or 2 days earlier, have a technical run also.
Yeah. Yes.
Why it is not coming? It is showing me it is there, but
You stop sharing once again and then
Yeah.
you do the what you call full screen there, minimize the zoom and then share.
okay. Sharing. So this was my downloads.
You are sharing the screen. I think you should share the PPT slides where you have opened it.
It was in the downloads.
No. You open the PPT once, make it full screen. First minimize the zoom, then go to the PPT, open it, make it full size, and then you share from the zoom.
Okay, so minimize this. Okay. Sir, is it visible now?
Yeah,
Yeah.
make it full screen, make it full
Yeah.
screen.
So now I'll go to the slideshows. So is it okay
Fine.
now?
Yeah.
Now go ahead, please.
Yeah, okay. So, most patients who undergo surgical procedures, they experience acute pain, and evidence suggests that less than 50% report adequate postoperative pain relief. And approximately 70% of the patients, they experience moderate to severe pain, and if improperly treated, it results in chronic pain. So as Dr. Vinita already discussed about like what is the chronic pain, any pain which is lasting for more than 3 months is chronic. And the pain following surgery, they usually initiate a variety of mechanisms, including the inflammatory, visceral, or somatic type of pain. So this is just a brief review of like how bad is the incidence of chronic post-surgical pain. So as you can see that the highest incidence is with the amputation with almost like 30 to 85%, and even with 12 months duration, it is 75% in the lower limbs. And there are other major surgeries such as thoracotomy, which leads to 5 to 71%, then mastectomies, 57%, craniotomies. So all these surgeries are associated with a highest percentage of chronic post-surgical pain if not treated properly. So poorly controlled pain can lead to patient having tachycardias, ischemias, hypercoagulable state leading to DVTs, and most importantly, the respiratory complications such as tachypnea, they are not able to generate adequate tidal volume. Psychological, such as patients are having depression, sleep deprivation, anxiety due to poorly controlled pain, and it leads to prolonged hospital stay, increased hospital admission, opioid usages. For the healthcare personnel, it leads to low morale, why the patient is not getting better with their current treatment, increased use of hospital resources, and it also leads to increased litigations or medical legal cases. So what are the goals of post-op pain management? So to reduce acute and chronic pain, to improve the quality of life, to reduce morbidity, and to facilitate rapid recovery and early hospital discharge. So what are the management strategies for post-operative pain Usually it is targeted as multimodal analgesia, which is recommended by most of our anesthesia and regional anesthesia bodies. It includes pharmacological methods as well as non-pharmacological methods. So pharmacological methods, as we all know, it may include acetaminophen, NSAIDs, opioids, and other agonists like clonidine, dexmedetomidine. Apart from that, regional anesthesia plays a very important role in managing postoperative pain. So it can be with neuraxial blocks, peripheral nerve blocks, or continuous catheters, or local anesthesia infiltration at the incision site. So my particular talk is focused on this topic. Other non-pharmacological techniques which we can use for as a multimodal analgesia are TENS, CBD, music, or audio analgesia. So this is just a brief review, like how the acute pain can transition to chronic pain. So if there is a surgical or pathology or a fracture that leads to different kinds of trigger of the nociceptive systems or the surgical trauma leading to tissue injury. And there are many factors which can actually cause acute pain to convert into a chronic pain, depending on the type of the surgery, the type of perioperative analgesia, what we are planning, perioperative factors such as what is the age of the patient, what is the gender of the patient, what are their socio-economical factors, like mostly like highly educated or high profile patients, they have very less tolerance towards pain, and later on leading to like some biological factors. So all these factors can increase the post-surgical pain, their intensity, their duration, and otherwise also they can lead to some pain modulation mechanism, which madam has already described at different levels, and increase in the pain catastrophizing. All these lead to change in molecular mechanism at the brain and in the spinal level, along with the stress response to the surgery, can lead to increased post-surgical pain. And if that is not controlled, can lead to chronic post-surgical pain. surgical pain. So what are the different regional anesthesia modalities which we are using in our day-to-day practice? Central neuroaxial blocks, peripheral nerve blocks, local infiltration, and intravenous regional anesthesia. So I'll be focusing on the first three, as IVRA does not lead to that much prolonged postoperative analgesia. It is basically an intraoperative modality. So we all know spinal anesthesia. We have been taught from our first year that it is the bread and butter of the anesthesiologist. And it was the first regional anesthesia technique to be developed in Germany by Dr. August Bayer. And the LA is directly delivered into the subarachnoid space, and it is usually performed in the lumbar areas. Usually used for the surgeries involving lower abdomen, pelvis, perineal, or lower abdominal surgeries. And it can either be used alone most of the times or as an adjunct to GA, depending upon what kind of surgery we are doing. The effect can be prolonged in the postoperative period by addition of adjuvants intrathecally, such as opioids, fentanyl, morphine, or alpha-2 agonist, clonidine. Next is epidural anesthesia or analgesia. It can be used for intra as well as postoperative analgesia, and the drugs are directly injected into the epidural space to block motor and sensory spinal nerve roots. It can be used for a variety of procedures involving from thoracic, abdominal, pelvic, or lower extremities areas. It can be either intermittent or through continuous infusion, depending upon what kind of local anesthetics and other adjuvants we are using. We can easily prolong the duration of analgesia. The advantages are it leads to reduction in opioids requirement. It lowers the incidence of adverse effects associated with GA. So what are the advantages and disadvantages of these neuraxial blocks? So advantages are it leads to better pain control, less need for systemic opioids, faster recovery of your bowel functions, less postoperative pulmonary complications, and early ambulation and participation in physical therapy. Disadvantages are the most common one which we see with the neuraxial blocks are the urinary retention, post-dural puncture, headache, nausea, vomiting, any neurological injury, total spinal anesthesia, spinal hematoma, TNS, specifically with lidocaine. Nowadays, we are not using it, and arachnoiditis if we are not maintaining proper sterility. Now, coming on to the combined spinal epidural anesthesia, how it is like, it is really beneficial. Like you can give the spinal drugs so that it will start acting rapidly and can easily use the epidural catheter, which can be extended into the postoperative area to enhance the analgesia for extended periods. So the clinical applications include general surgery, orthopedics, trauma surgeries, urological and gynecological surgeries. It is very commonly used in labor and cesarean delivery. The presence of epidural catheter is also known as the safety net, which can lead, it can be then converted into the anesthesia followed by analgesia with the epidural catheter. Coming on to the next modality, which is very common in the pediatric population, is the caudal epidural. The patients undergoing lower abdominal surgeries such as inguinal hernia, urological and lower extremity surgeries. It is also used, and the use has been extrapolated in the adults for having anorectal surgeries and in chronic pain management. It can either be in a sole anesthesia or in combination with general anesthesia. It is very easy to learn with good outcome, and it can either be done by landmark guided or ultrasound guided. So coming on to the another modality, where the peripheral nerve blocks. So peripheral nerve blocks we have been using because of the advent of ultrasound guide. Earlier we were using landmark guided or anatomically, but with the use of ultrasound guided, we can literally block from head to toe, like whatever nerves we are able to see. So they have a very wide use for surgical anesthesia as well as for both postoperative and non-surgical analgesia. And they offer distinct benefits over general as well as neuraxial anesthesia in certain clinical situation and certain population in which these other modalities are contraindicated or we cannot use them. They provide analgesia that may be superior to other techniques. Indications of peripheral nerve blocks, they are very diverse and very wide. The most common rationale is to avoid side effects and complications of general anesthesia, particularly the respiratory related effects, and to provide analgesia while minimizing the opioid usage. So this is one of the article which I found where is a narrative review on the nerve blocks for post-surgical pain management. It was from the Journal of Pain Research. So they have found emerging evidence suggests that nerve blocks can be as effective as opioids in managing pain, while potentially offering additional benefits such as faster recovery, improved patient satisfaction, and reduced reliance on opioids. So some of the examples of the upper extremity blocks, I will not go into the details of each and every block because they are, I think, more than 50. So I will just focus on what are the major blocks which we are using in our day-to-day practice. So most common of them is the brachial plexus block, or supraclavicular brachial plexus, or the interscalene brachial plexus, axillary brachial plexus, and they can be, depending upon where is the location of the surgery, they can be used if there is upper limb surgery, shoulder, arm, and hand. Whole of the supraclavicular brachial plexus can be given. If it is only the arm and the forearm and the hand, then axillary brachial plexus can be given. If we want to insert a catheter, then infraclavicular brachial plexus is a really good position for the catheter, and it can be prolonged for the at least for 2 to 3 days for continuous and intermittent boluses through the contiplex catheter. However, we should be mindful that interscalene brachial plexus, they can lead to some potential complications, including phrenic nerve blockage. So we should be cautious in patients who are asthmatic and COPD or emphysematous. Some of the lower extremity blocks which we commonly use in our practice are the femoral nerve block, and recently we are using more of PENG block in the hip replacement surgeries or hip arthroplasty along with the general anesthesia that leads to reduced pain during the movement, faster recovery, lower opioid use. So basically there are many blocks which we can use depending upon where we have the surgery. Lumbar and sacral plexus, it can be used for the whole lower limb surgery such as hip and femoral surgeries, and the advantages are the patients are having stable hemodynamics and reduce hospital stays and lower costs. Other blocks which we use, or the regional anesthesia techniques which we use for most commonly, are the adductor canal block for the total knee arthroplasty, and local anesthetic infiltration which we can use for various surgeries including hip and knee, like sciatic nerve block, popliteal nerve block for the below knee and ankle surgeries. They have very good, some of the patients, they are not hemodynamically stable and they come with cellulitis, gangrenes. In those patients, these blocks are really, really beneficial. So truncal and cutaneous nerve blocks, or the fascial plane blocks, they are very commonly used. TAP block is one of them, my favorite. And it has been used for providing post-operative analgesia for laparotomy, appendicectomy, cesarean sections, either elective or emergency. And it can also be an alternative to epidural anesthesia for operations on the abdominal wall. Other blocks such as ilioinguinal, iliohypogastric can be utilized in pediatric patients also who are undergoing ilioinguinal hernia repairs or analgesia following the suprapubic incision. Chordatus lumborum can also be utilized for abdominal surgeries above or below umbilicus, also in the elective LSCS. So this is one of the paper, and this was my thesis topic, and where we did a comparison of TAP block and caudal block for providing post-operative analgesia in children undergoing lower abdominal surgery. And because of this thesis, I became a regional anesthesia enthusiast, and that's how I became a pain physician also. So we concluded that the duration of analgesia was significantly longer in children who received TAP block as compared to caudal block, and it is a good alternative for providing post-operative analgesia. So these are some of the examples of nerve block techniques which can be used in various surgeries. Supposedly you are unable or you are not that much proficient to do a paravertebral block for any major abdominal or thoracic surgeries. So instead of this, you can do a erector spinae plane block, which is comparatively which is comparatively easier and as much as effective as a paravertebral block. So coming on to some of the examples of the chest wall blocks like PEC1, PEC2, serratus anterior plane blocks, which can be done for variety of cardiac, thoracic, and breast surgeries, or intercostal nerve blocks, which can be given for your lap cholecystectomy as well as for your mastectomies if they are covering that region. So coming on to the new other block, the scalp block, this technique was originally introduced more than a century ago, and we used to do it in our practice as the landmark guided technique. And because of the current age on like minimally invasive surgeries and the surgeons offering for like more awake craniotomy, that interest has been renewed. And basically we are blocking 5 nerves in the scalp, because the third occipital nerve, the greater occipital nerve, and supratrochlear, supraorbital in the forehead, auriculotemporal, zygomaticotemporal. So, and there was one of the paper which Dr. Uma Maheshwara Rao has written as an editorial, so precise scalp block. And apart from providing intraoperative analgesia, it analgesic effect extends into the postoperative period depending on the anesthetic technique and the drugs used. And they are very, very useful when the surgeons are doing their pinning response. So once, and they have very better control of hemodynamics to painful events such as skull pin fixation and skin incision. So when I was in Canada, they never used to do scalp block, despite telling me that in India we do scalp blocks for the pinning. But no, they wanted to give remifentanil as an infusion. But I found that giving scalp block after the general anesthesia provided very stable heart rate and hemodynamics for the patient before they go for any skull or pin fixation. So this is another paper which was done by my team. We had these moya patients, and we did a anesthesia point of view implications. And during this procedures, we offered scalp block for all the pediatric patients, and we found that scalp block was very effective in reducing post-operative pain and crying, and thus the ischemic episodes and overall neurological complications which was associated with the crying in the moya disease was reduced. So I found this literature review where there was a clinical consensus on clinical practical guidelines from the American Pain Society, ASRA, as well as the ASA on the regional anesthesia. So this is a expert panel which was formulated, and they addressed various aspects of management of postoperative pain, including the perioperative education, perioperative pain management planning, and use of different pharmacological, non-pharmacological modalities. So they gave 32 recommendations, and out of them, 4 were assessed as being supported by high quality evidence. And out of them, the 2 recommends that the surgical site specific peripheral regional anesthetic techniques in adults and children's. And the panel also recommends that offering neuraxial analgesia for major thoracic and abdominal procedures, particularly in patients at risk for cardiac complications, pulmonary complications, or prolonged ileus. So, apart from that, they also recommended use of multimodal analgesia and techniques combined with non-pharmacological interventions for the treatment of better management of postoperative pain in both adults and children, as well as use of acetaminophen or aniside as part of multimodal analgesia in patients who are having no contraindications of these drugs. Some updates on the wound infiltration we commonly see in our day-to-day practice. We ask the surgeon, please sir, give some local infiltration. We were not able to put any epidural, or there was no time to give any regional anesthesia block. So these are the updates on wound infiltration for use of postoperative pain management. It was from the Journal of Clinical Medicine. So they have used single wound infiltration techniques with local anesthetic, as well as the continuous local anesthetic infusions which were placed through catheters into the surgical wounds. And they found that they have been part as of an integral part of the multimodal analgesia scheme for better management of postoperative pain control. And the advantages of these wound infiltration techniques are they are safe, they are cheap, they are simple, and they enhance postoperative analgesia, especially during mobilization. So these are the recommendations which are done by the Prospect Group. So Prospect Group is formed by the European Society of Regional Anesthesia, and this is a group which includes close working of the surgeons as well as the anesthesiologists for the better controlment of the post-operative pain. So some of the indications or some of the surgeries which they indicate for the wound infiltration, either single or with continuous wound infiltration with catheters, they are cesarean sections and the open colorectal surgery, inguinal hernia repair, laparoscopic cholecystectomy, some oncological breast surgeries, radical prostatectomies. Apart from lumbar laminectomy, where we commonly see that surgeons they do infiltrate before the skin closure. Some of the techniques where this where they can be this technique can be extrapolated, but specific procedure specific evidence is less, but still it could be beneficial. So they include like emergency surgery through laparotomy, open hepatic surgery, thyroidectomy, VATS, neurosurgery, cardiosurgery, and some open knee surgeries apart from the TKR, etc. So how do we do these wound infiltration techniques? So this panel recommends use of smaller diameter needles, 27 to 30 gauge. Injecting rate should be slow and we should give some pause. And the needle for the first intradermal injection for anesthesia should be perpendicular as it passes through few pain fibers and thus reduces the pain. And when we are combining this technique with other regional anesthesia, we should calculate the dose of local anesthetic along with the regional anesthetic to prevent toxicity. Addition of epinephrine with the lidocaine, which we commonly do, has a pH of around like 4.2, which is more acidic than our physiological or biological pH, and it causes greater pain intensity during injection. However, on the contrast, if we do buffering of the lidocaine with sodium bicarbonate, it significantly reduces the pain on injection as the pH becomes more or less alkaline and more physiological. So these are some of the Prospect guidelines for Prospect has given guidelines for many surgical procedures. You can check on their website. It is on ESRA. And I have included few guidelines which we are commonly encountering, such as for elective cesarean sections, total hip replacements, and TKR. So for the guidelines for cesarean section, for the preoperative period, they recommend use of intrathecal long opioid acting opioids such as morphine or epidural morphine as a part of combined spinal epidural technique. In intraoperative after delivery, if intrathecal morphine was not used, local anesthetic wound infiltration, either single shot or continuous wound infusion or facial plane blocks such as stab block, erector spinae blocks or quadratus lumborum blocks should be incorporated. These are some of the guidelines for the total knee arthroplasty, in which they recommend using either single shot adductor canal block administered preoperatively and periarticular local infiltration analgesia administered intraoperatively. So a combination of these techniques is preferred for better postoperative analgesia. Similarly, we have like some guidelines for the total hip arthroplasty, in which they have used single shot fascia iliaca block or local infiltration analgesia. Nowadays, we are using PENG block, which gives intraoperative analgesia as well as, and it continues into the postoperative period. So the take-home message is regional anesthesia has become one of the mainstays of postoperative pain management. It provides significant reduction of perioperative pain, leading to improved patient outcomes. However, there are many risks and benefits which should be evaluated for any technique, and it should be carefully discussed with the surgeon, the type of procedure they are doing, how is the patient, and the anesthesiologist's preference. With the advent of ultrasound, peripheral nerve blocks have become more safe and precise, and we should incorporate specific protocols to conduct regional anesthetic procedures so that we can ensure maximum patient safety and improvise patient outcomes. So that was my last slide, and I cordially invite everyone for the National Pain Conference for the Indian Society of Study of Pain, which is we are going to organize in Hyderabad in the month of February 2026. So it will be The theme is emerging trends in pain medicine, and whosoever like regional anesthesia enthusiasts who have inclination towards pain can please join this enriching conference and workshop. Thank you.
Thank you, Dr. Neha, for taking us through the various techniques of regional analgesia and anesthesia for post-operative pain management. I think all anesthesiologists and their patients are looking forward to more of regional analgesia techniques for elevating pain than taking systemic analgesics. So it's a nice presentation, including the guidelines as well. We'll take, there are a few questions. We will take them at the end of all the presentations. So thank you. At this outset, I wish to thank all the participants and listeners who have patiently waited for the technical issue to be solved in. We'll go back to the previous presenter, Dr. Nitika. Dr. Nitika, can you please share your screen? And she will summarize briefly what our initial presentation was and then take us to the remaining slides. Over to you, Dr. Nitika.
Thank you, sir, and extremely sorry for that technical glitch, which I have sorted out, luckily now. I hope my screen is visible.
Full screen, please. Yeah, perfect.
Right. So basically, I'll summarize what I initially in my previous slides. I was actually telling the importance of taking the history, how it is important that the history taking should be taken in a detailed manner, and it should be a two-way communication with the patient as well as the doctor. The patient should not feel that the doctor is not listening to the problem, and is basically the doctor has to be empathetic towards the problems the patient is facing. So the history taking is basically followed in the following points: the Socrates, the site, onset, character, radiation, association, time course, the exacerbating and the relieving factors, and the severity of the pain. The mode of onset has to be looked into, whether it was sudden or gradual in onset, the severity of the pain. There are various scales which are available, and I'll be discussing. So the unidimensional and the multidimensional pain scales. So these are basically the subjective pain assessment. So unidimensional is basically the assessment of the pain in a single direction, which includes numeric rating scale, the visual analog scale, the faces rating scale, and the visual rating scale. The multidimensional scale includes the McGill pain questionnaire, the brief pain inventory, and the West Haven Yale multidimensional pain inventory. So numeric rating scale basically assesses the pain in a single direction. From 0 to 10, the patient is asked whether to score how severe the pain is on a scale of 0 to 10. So it is most commonly used pain scale in most of the pain clinics. And the advantage is that it is simple and easily understood by the patient. The disadvantage is that it has a ceiling effect, that if the patient, the pain is so severe, the maximum score can be given here is only 10. So there is no way to express the actual severity of the pain. While in visual analog scale, a scale from 0 to 100 millimeters, that is shown to a patient, and the patient is asked to to tell how severe the pain is on the scale from 0 to 10. So it has an advantage that it is sensitive to smaller changes. Even of 0.5, the patient can just exactly point out the how severe that pain is, and it takes less than 1 minute to complete, and there is no training is required for this scoring, and there is minimum translational difficulties with this scale. While the limitations include that it is subjective, it has less value for comparing across the different individuals, and cannot be administered verbally or on telephone. So it has to be shown to the patient, and then only it can be assessed. Then verbal rating scale is basically it is the scoring of the pain based depends upon the few words, whether it is mild, moderate, severe, or very severe. So here again, the problem lies that the patient cannot tell how severe actually the pain is, because it can just be expressed in terms of few words, whether it is severe or it is very severe. So the limitation is that the change in pain from mild to moderate or to severe cannot be actually expressed in terms of any number. And there is limited number of choices, only few words the patient has to express the severity of the pain. The advantage is that it is simple and easy to score, and it has better compliance and it has established validity. Then FACES rating scale is basically done in children who are over the 3 years or more of age, and in this different figures they are shown to the children, and children as well as adults, and patients with mild to moderate cognitive impairment and with language issues. We can show the different faces ranging from no hurt to hurt, worst, and they can just tell how severe the pain is depending upon the face. Then coming to the multi-dimensional pain scales, which includes McGill pain questionnaire. So it is most widely used, and it basically assesses the pain component in emotional, psychological, and besides giving a pain score from 0 to 10, it also has like affective, evaluative, and temporal aspects of pain they are dealt in this pain questionnaire. And the patient selects the words describing their pain. Their word selection, they are converted into the pain rating index, and it has basically the validity in expressing the multi-dimensional pain. So advantage is that it is valid, and it is reliable and consistent, and it discriminates between the different pain syndromes, and it is sensitive to change with amount of pain in response to therapies. The disadvantage is that it is lengthy and it is time consuming. So since it was lengthy, so there is now a newer form of pain questionnaire, that is the short form McGill pain questionnaire. It comprises of only 15 item questionnaire, and this the patient is asked to rate the pain to each of the descriptors in terms of 0 to 3. So it assesses the sensory, affective, and the total pain index. And advantage is that it can discriminate amongst the different pain conditions, and it is easier than the original McGill pain questionnaire for geriatric patients especially. So the impact committee recommended the use of this short form as compared to the other original McGill pain questionnaire for assessing the pain. So this is basically the 15 components which are dealt in the short form of McGill pain questionnaire, and the VAS score and the pain severity, that is the present pain index that is expressed. Then coming to how to assess the quality, the nature of the pain. So we have to assess what is the quality, whether it is nociceptive, as has been discussed in the previous presentation, it is nociceptive or neuropathic, or is it mixed. So neuropathic pain is any pain which is arising as a direct or indirect consequence of lesion or disease affecting the somatosensory nervous system. So there are validated questionnaires which basically assess they are the screening tools for whether the pain is neuropathic or nociceptive. So neuropathic pain will have a burning sensation, it will be associated with tingling, numbness, and crawling of ants, or cramp-like pain, electric shock-like pain, and it would have allodynia. It would be associated with suffering, depression. It may be associated with emotional components also. So the various pain disorders which are which come under neuropathic pain include peripheral neuropathies, post-herpetic neuralgia, trigeminal neuralgia, central post-stroke syndrome. Then mixed pain includes migraine, fibromyalgia. Then nociceptive is secondary to mechanical low back pain, osteoarthritis, rheumatoid arthritis. So what are the screening tools for basically the neuropathic pain, whether the pain is neuropathic or it's nociceptive? So we have these, which includes Leeds assessment of neuropathic signs and symptoms, the LANS questionnaire, neuropathic pain questionnaire, the pain detect tool, ID pain, and Doloro neuropathic N questionnaire. So DN4 questionnaire, which we commonly use in the pain clinics. So coming to the LANS questionnaire, so it was the first screening tool which was described for neuropathic pain. It comprises of 5 symptoms and 2 signs, and it basically has a binary response to the signs and symptoms. So it is easy to score and has a high sensitivity of 82 to 91%. So these, as you can see, the 5 symptoms and 2 signs, it includes, and the score is given out of 24. So more than or equal to 12 is diagnostic of neuropathic pain. The other questionnaire for neuropathic pain is the neuropathic pain questionnaire, which is also scored on a scale of 0 to 100. So it basically includes the 3 items, the presence of numbness, tingling, and the increase of pain to touch. So if these are scored on 0 to 10, so this basically, depending upon the score, the patient pain is diagnosed as a neuropathic pain, and it has a sensitivity and specificity of 66 and 75%. The other screening tool is the pain detect tool, and it is also simple and self-reported pain questionnaire. It includes 9 items, which include the 7 sensory, 2 spatial, and 1 temporal. The 2 spatial and temporal characteristics, and it has a scale of 0 to 5. And in this we can assess for the presence of the symptoms, which include burning or presence of tingling pain. Is the light touch painful? How is the pain? Is it electric shock like? Is there any change in the temperature sensation? numbness is present, or does light pressure trigger pain? So out of these, we have to assess the pain course also. So if the score is less than or equal to 12, the neuropathic pain is unlikely. And if the score is more than or equal to 19, it is highly likelihood that neuropathic pain is present. So it has a sensitivity and specificity of 85 and 80%. So then during the assessment, we have checked for the screening tool for the neuropathic pain. We have to see what is any special character is associated with pain. So if the patient has a deep boring or wrenching or retroorbital pain, so certain type of pains, they have associated with special characters. Like in cluster headache, it presents as a retroorbital, deep boring or a wrenching pain. Vascular headache will be throbbing, pulsatile, and it would be severe and sudden in onset. Trigeminal neuralgia would be unilateral, paroxysmal, and current-like sharp shooting. And pain of TM joint dysfunction would be unilateral, dull aching around that affected joint. So there are certain type of pain which are associated with special character. So post-herpetic neuralgia would also be associated with burning and aching superimposed on paroxysms of shocks and jab-like pain. So any relation with the posture, pain on sitting, as we do for any low back pain patient, if the pain increases on sitting, then it can be doubtful of a SI joint arthropathy. And cross leg position, pain occurring in a cross leg position can be diagnostic of piriformis. Then pain on posture changes, turning in bed can be a diagnostic of facet joint. Prolonged sitting, more pain in discogenic can be diagnostic of discogenic. Then spinal canal stenosis, there is pain on prolonged standing and prolonged walking. Then presence of any associated complaints like weakness, numbness. So we have to check for those also. That can be diagnostic of any neurological deficits, any fever or nausea, vomiting. That has to be ruled out. So while taking the history in any pain patient, we have to rule out certain presence of certain red flags, yellow flags, blue flags, and the black flags. So what are red flags? Basically, any new onset of fever or loss of appetite or presence of any motor disturbances, bowel and bladder disturbance in any patient which is presenting with pain. Any exacerbation of pain in a patient with pre-existing baseline pain. So we have to basically rule out the presence of any organic pathology. So there can be certain, and then what are the yellow flags? Yellow flags are basically certain beliefs and abnormal beliefs regarding the pain. The patient might be feeling that I will never recover from pain, and this pain is leading to basically a negative attitude towards the recovery towards pain. So we have to find out whether the patient is basically how prone to recovery, or what are the coping strategies the patient has. If the patient is not able to cope with the distress which is associated with the pain, so we have to find out, and we have to manage. Basically, it will help in further management of pain, whether the patient requires further psychiatric reference or not. How is the patient's behavior towards the pain? Any willingness in the patient to adapt to the change in with regard to the pain. Then there are certain blue flags. Blue flags are related to the work environment. So any factors which are present in the work culture, which are inhibiting the patient's recovery from pain. So we have to identify that also. Is there any presence of modifiable factor? If the patient is working in a factory and he is lifting the heavy weights regularly, so we modify the work environment so that the patient does not have to lift the heavy weights and can go on to the recovery mode. And then black flags are basically certain unmodifiable factors which totally basically that cannot be changed at all. So these have to be identified, and the patient has to be counseled regarding if they are present, then that can inhibit the patient's recovery towards pain. So it is important that when we are assessing the patient's pain, we identify all these red, yellow, blue, and black flags and counsel the patient accordingly so that the patient has early recovery to the pain. Then coming to the timing of the pain, if there is pain and stiffness in the morning, so it can be diagnostic of inflammatory arthropathy. And if there is pain after inactivity, which is persisting less than 30 minutes, then it can be degenerative. If it is pain persisting for more than 30 minutes or more than many hours, then it is inflammatory. Then severe headache occurring regularly at particular time, particular season, it can be a cluster headache. And neuropathic pains, they present they have more severity in the night. Then how is the duration and frequency? So that also needs to be assessed. Any provocative and relieving factors, like in leg and back pain patients due to spinal stenosis, the patient will say that after walking for some time, when he sits or he lies down supine, then there is relief of the pain. While in neuropathic pain, it is also certain types of like trigeminal neuralgia, exposure to cold touch can lead to exacerbation, sudden onset of the pain. So we ask the patient to keep the face covered. So we have to identify what are the provocative and the relieving factors for each type of pain. Then apart from this, then it is important to the psychological evaluation of the patient. So we have to assess how the activities are affecting the patient's pain, how the pain is affecting the patient's activities, how is your pain, sleep, appetite, physical activities, they are being affected, and how do you deal, and how you are coping, what are the activities which are making it better or worse, and how do you think your pain will ever get better, and have you been feeling worried or depressed, how do people respond to your pain. Then after the assessment, basically what the patient has to, it is important that the patient basically keeps a pain diary and notes what are the timing of the day the pain started, and the characteristics and the location and the measures which were taken to alleviate that pain. And these are helpful in the follow-up visits also. And each basically on each pain the score is given. So this is basically a photo of a pain diary in which the date, time, the pain scale rating, the medication and the dose which were used to relieve the pain, and what made the pain better, what made the pain worse. So all the factors related to the pain, that is noted. So after these all subjective parameters, there are certain objective parameters also, in which we have to look at the behavior of the patient. How is the verbalization, the vocal response, the facial and the body movements, and the social interactions. So these are basically the patient which the patient is not telling you directly, but we have to assess by the patient's behavior. The facial expression of the patient is the first indication. The vocalization, whether the patient is moaning, groaning, crying, or grunting, or screaming in pain. And then certain factors like increased in blood pressure, the heart rate, pulse rate, the respiration, whether there is presence of pallor, diaphoresis, and pupillary dilatation. So these can also be and give you objectively assessment of how severe the pain is. Then after the basically the history, we do this certain physical examination, the general physical examination, specific pain evaluation, neurological examination, musculoskeletal, and assessment of the psychosocial factors. Then in the general, we look for the mental status, the presence of cognitive impairment, mood, the evidence of any cognitive impairment is there or not. How is the general appearance of the patient, the blood pressure, the gait of the patient, the aids for mobilization which is being used, any signs of substance use, and any evidence of any tremors, muscle atrophy, trophic changes, or any deformities. So there are different type of gait. The patient in pain can have the mentalgic gait, which is commonly seen in low back pain patients. They do not give pressure on the painful side. They give more pressure on the non-painful side of the basically the leg. And then there can be steppage gait seen in patients with like the foot drop. So these are basically the different type of gaits the patient can have. Then we have to look for how is the posture, the behavior of the patient. Any presence of limb length discrepancy can be there. Then palpate for the presence of any tenderness, swelling, crepitus, contour, or bogginess in case of joint pain. Then any presence of trigger points. Then certain tests which we can do individually, like for presence of any swelling, crepitus, redness, muscle tone, and muscle strength. So the patients in the low back pain patients, depending upon the nerve root pathology, we can assess for the actually what is the distribution of pain, whether it is following a particular dermatome or not. So we have to observe for the skin lesions, the swelling, any presence of swelling area, swelling in the painful area, changes in the skin color, altered swelling, any trophic changes, autonomic dysfunctions, or involuntary movements. Then Then in the neurological examination also there is cranial nerve examination, which I will not be going into much detail. Then in the spinal examination, we look for the inspection presence of any how is the posture of the cervical and the thoracolumbar spine and the lumbar spine, and abnormal presence of any abnormal kyphosis, lordosis, or scoliosis, any palpation of the spinal processes, any presence of localized tenderness, then sudden change in prominence of the spinous processes, or any presence of vertebral fracture. Tenderness in the paraspinous region can be indicative of facial arthropathy or myofascial pain syndrome. The range of motion of the spine that is assessed, the normal range of cervical spine is 60 degrees forward and 75 degrees extension, and 45 degrees lateral flexion and 80 degrees lateral rotation. So we have to look what is the normal range of the cervical and the lumbar spine. If there is improvement in the range of motion with supine position in cases of muscle spasm, and there is no, then it is basically cervical arthropathy. Then Spurgling maneuver can be done in patients who are suspected of cervical radiculopathy. Then thoracolumbar spine, the normal range of motion is 90 degrees forward flexion, 30 degrees backward extension, and 25 degrees lateral flexion, and 60 degrees lateral rotation. So pain provoked by back extension and lateral rotation can also be suggestive of facet arthropathy. Pain provoked by back flexion is seen in discogenic and vertebral body as a source of pain. And lumbar discogenic pain, it has a restricted, it increases on sitting, and pain is provoked by coughing, sneezing, and on Valsalva maneuver. So again, we can do certain, basically the examination of the various muscles of the upper and the lower limb to assess for any presence of motor weakness or not. So that also I will not be going into detailed assessment of the motor examination. Then myofascial examination, in this we palpate for presence of any tender points or tender bands. Trigger points can be basically assessed. Then active myofascial trigger points, there is basically, while pressing, it would result in the triggering of the pain to the adjacent structures, and it would lead to the restricted range of motions. And while the latent trigger points, they are tender and palpable, but there is no spontaneous pain. There would be spontaneous pain in active myofascial trigger points. Then, and it would appear as a nodular. The trigger points would appear as basically the nodules which are present in the while palpating the muscles, and they can produce a local or a referred pain to the surrounding structures. Then after this myofascial examination, we do the sensory testing, the temperature, any present temperature changes or pinprick or proprioception or the vibration sense that is tested. So basically, as has been described in the previous presentation, the A delta and C fibers, they carry the pinprick and the temperature sensations through the lateral spinothalamic tract, while the proprioception and the vibration sensation is carried by the A beta fibers through the dorsal column in the spinothalamic tract, spinal columns. So temperature sense can be checked by the cold metal portion of the tuning fork, while warm sensation can be checked by using the warm water in the test tube. So, and the proprioception can be used by checking the position of the interphalangeal joint of the big toe, while the vibration sense is used by using the tuning fork. So any alterations can be checked, which can be includes hyperesthesia, sensations which is out of proportion to the stimulus applied. It can be further divided into hyperalgesia and allodynia. Hyperalgesia is severe pain in response to mild noxious stimulus, while allodynia is sensation of pain in absence of any noxious stimulus. Then in this also, we have specific diagnostic study to rule out the neuropathic pain, which includes the quantitative sensory testing, diagnostic nerve blocks, rheumatological tests, pharmacological and conventional radiography, CT, MRI, and nerve conduction studies, which can be done. So basically, in quantitative sensory testing, it is a subjective experience, measures the subjective experience in response to thermal, mechanical, and vibratory stimuli. And basically, in this, the patient completes a pain diagram, and there is mapping out the area of abnormality, and starting with the normal area and progressing to the abnormal area. So establish a controlled site where the patient has no sensory abnormality and pain, and then testing is done separately for the abnormal and the abnormals. Basically, in this, what we do is that we can use a one phase filaments, in which we apply check for the pressure pain thresholds, then thermal sensations and the vibratory stimuli, they are checked, and a graded stimuli that is applied at each of the areas in which the patient has pain. So that pressure at which the patient has pain, that is recorded, and it can be used for the assessment of certain interventions, presently we are doing one study on quantitative sensory testing, in which we are recruiting low back pain patients, and they are enrolled for the yoga therapy, and after a few months, like 6 months of yoga therapy, the quantitative sensory testing is being repeated in them. So this is basically the study which is presently under the recruitment phase, and the results have not been come yet. And then after the assessment and the examination of patient, we do the follow-up. In the follow-up visit, what we have to basically check, we review whether the goal has been achieved, whether the pain relief has been present or not, our intervention or the medication therapy, was it successful, did it actually the patient responded to it or not. And if the patient is maintaining any pain diary, we have to check what was the severity and how many what the medication the patient took in the previous days the patient had pain. So we need to document the analgesic response, both to the pain score and the function, and what was the activity of the patient, was there any adverse effects secondary to the treatment, and how was the drug related behavior, if the patient was started on opioids and cannabinoids, and what is the next plan of action after this management.
Dr. Nitika, maybe you can summarize.
Yes, sir.
Because we have 3 more presentations to go in the next 1 hour.
This is just last of my slides only. This is basically the pain evaluation form, which is filled for every new patient which is coming to our pain clinic here. So we firstly the demographic details and the chief complaint. We look how is the onset of the pain, the progression, the pain characteristic, the location of the pain that is marked. How is the pain, constant or episodic, any diurnal variation, any postural variation, any radiation or referred pain, the precipitating factors, the relieving factors, then the pain score on 0 to 10, then effect of the patient on the patient's activity, then any past history of trauma or surgery or any dental extraction, any comorbidities, and the treatment history the patient took. Then the examination, we look for all the vital parameters and the range of motion, the sensory examination is done, the motor examination, and then any relevant investigation which is present with the patient on the first visit. And we make a provisional diagnosis and advise the treatment. This is the examination details in which the motor and all the tests are done. So in head and neck also the various local examination which is done, and follow-up visit, we note down the treatment the patient had received and look for what is the present NRS and how much is the improvement in the pain as compared to the first visit, any side effect, any presence of new or additional finding, and what is the further treatment that is advised. So this is how basically the pain assessment is done for any pain patient which is reporting to our pain clinic. So this was my presentation. Thank you so much, and sorry again for the technical glitch that was present initially.
No problem. Thank you, Dr. Nitika. I think pain assessment is very important to accurately diagnose a patient, and of course to tailor our treatment and also monitor the treatment that is provided to the patient. And Dr. Nikita has provided a comprehensive overview of the assessment of acute and chronic pain. Thank you very much. We'll move on to the next presentation. We have 3 more presentations in the next 1 hour. The next one is on the overview of common chronic pain conditions. Some of the common pain conditions are already briefly touched upon by the previous speakers. And to cover this topic, we have Dr. Jaishnu Tople. I request Dr. Nitika to please stop sharing your slides so that Dr. Tople can share his presentation. Dr. Jeshnu Tople did his MBBS, DA, and DNB in anesthesiology, followed by FIPP USA and European Diploma in Pain Management in Belgium, FIAPM and FIPM. He is currently the director of Mitigate Pain Clinic Nagpur, and he has several academic achievements, including Rising Star in Pain Medicine Award, Young Pain Physician of the Year Award, 18 publications and book chapter. He is a faculty at various conferences, and his area of interest include neuropathic pain and musculoskeletal pain. Over to you, Dr. Tople. You can start sharing your screen and start your presentation.
Yeah, I hope my screen is visible, sir.
Yeah, full screen, please.
Yeah, just a second.
Perfect.
Yeah. Okay, thank you for the kind introduction, sir. My topic is a bit simple and bit difficult because I have to cover most of the things, but cannot cover it in details. So I'll be touching on the few important pain conditions which we cover in our daily routine practice. So what the conditions I will be covering include about 90% of routine pain, chronic pain practice, but not the all conditions. Okay. So this is how I'll be going through my lecture. This has already been told by the previous speaker, but it is important to mention that in the update of 2020 definition, ISP has told that its personal experience, and we need to understand that pain and nociception are different phenomenon, and patients learn their pain through their life experiences, and whenever the patient report the pain, it should be respected. Although pain is usually adaptive role, but as we know that in chronic pain, it may have adverse effects on function and social and psychosocial well-being. So verbal description is only one of the several behaviors to express the pain, and we must understand that inability to maintain, inability to communicate does not negate the possibility that human or a non-human animal experiences pain. So why chronic pain is important? So you see, about 20% of our population, is affected by the chronic pain. And to understand this impact, let me tell you that about 11% of the population in India is suffering from diabetes mellitus. So approximately more than double of those suffering from diabetic mellitus are suffering from the chronic pain. This is how huge the problem exists in our society. And this 20% figure stands true for globally as well as for India. Dr. Ashok Saxena from Delhi has conducted a prevalence study, and he found that even in India, 20% of the population is suffering from chronic pain. So technically, we divide chronic pain into nociceptive and neuropathic or mixed or nowadays neuroplastic pain. But if you consider like from the clinical perspective, how the patients present, patient usually present primarily with the musculoskeletal pain complaints or neuropathic pain complaint, or mix of these two, or cancer pain. Cancer pain can again present itself as a musculoskeletal or neuropathic or a different dull aching type of pain. So I'll go through this main domain of the chronic pain conditions. So coming to musculoskeletal pain, musculoskeletal pain are mainly related to spine, joints, muscles, or it can be widespread, affecting the entire body. So let us consider one by one. So in spine, most commonly affected things are facet joints and sacroiliac joints, as well as intervertebral disc and sometimes vertebral bodies. In joints, apart from the joint itself, other components of joints like tendons, ligaments, and cartilage might get affected, and we as a pain physician treat it. Previous speaker, Dr. Nikita, talked about the myofascial pain syndrome. Also, neurological disorders can affect the muscles, and widespread pain like systemic illnesses like inflammatory arthritis and vasculitis and fibromyalgia. So coming to the spine, In spine, the most common condition which is related to the spinal pain is facet joint arthropathy or facet joint arthritis. This is a true synovial joint which is present on the posterolateral aspect of the posterior column of the spine, and it supports the spine and it gives stability to the spine during standing and rotational movement. And this being one of the most stressed joint of the spinal column, both in the cervical region as well as in the lumbar region, this is the most commonly affected one. Common individuals affected with these are elderly people or those who are into high impact sports activities requiring repeated rotational movements of the torso. Another important or second most common cause of back pain is your sacroiliac joint, which is formed by the sacrum and ilium. Obviously, it's both synovial as well as fibrocartilaginous joint, and it again is commonly affected in elderly age group or those have inflammatory arthropathy, and sometimes the accidents or trauma can affect this joint. Then very commonly we see disc patients, but let me tell you, disc patient doesn't always mean radiculitis. So in this figure, you can see this is just an illustration showing the normal disc, and the second one is a degenerative disc. This degenerative disc itself can be the cause of pain, especially in young population. In elder population, the degenerative disc might not be the cause of pain, but in young population, this is one of the very important cause of pain, where when patient bends forward or flexes the torso, there will be increase in the pressure on the disc, and this degenerative disc can cause irritation of the nerve endings, and that can lead to pain. So apart from that, bulging disc or herniated disc can lead to back pain as well as radicular pain because of impingement of the nerve roots. This can be this stands true for both lumbar spine as well as cervical spine. So, and then the anterior most part of your vertebral column are the fractures. But let me tell you, as a pain physician, we don't deal with the fracture where posterior cortex of the vertebral body is breached. This is the case for surgical intervention. But where the posterior part of the cortex is not breached, it's intact, and it is specifically the anterior wedge fracture, then we deal it with vertebroplasty or conservative treatment. And in day in and day out, we see a lot of joint pain patients, especially hip, knee, and shoulder joint patients. So commonly, these are affected due to degenerative changes in elderly age group. So what we do a lot of regenerative treatment for this patient, and sometimes if the joint is much degenerated in the grade 4 stages, then we can think of radio frequency ablation or cryoablation, provided the patient is not ready for replacement surgeries. But joints are not formed only by the bones. There are a lot of soft tissues in the joint. Common among them are tendons. Okay, so there are tendons can get affected in various ways. So there can be tenosynovitis, tendinitis, tendinosis, or partial or complete tear of tendon. What is tenosynovitis? There is a small sheath or connective tissue which covers the tendon, and if there is inflammation or degeneration of that sheath, we call it as a tenosynovitis. And what is tendinitis? Tendinitis is nothing but the inflammation of the tendon itself. It is usually an acute condition, and when it persists or when there is a gradual degeneration of the tendon, there can be tendinosis, that is degenerative changes in the tendon. And another thing which as a pain physician we treat are the partial tendon tears. It can be anything. So, but if there is a complete tendon tear, it usually needs the surgical correction. So what kind of things we deal with in daily practice? We deal with decurrence tenosynovitis, which is the pain at the base of thumb, one of the most common tenosynovitis. And what are the common other tendinopathies? We have tennis elbow or golfer's elbow, which are technically called as common flexor tendinosis or common extensor tendinosis. Then Another important thing which is commonly affected in elderly patients or diabetic patients are your rotator cuff tendinitis or rotator cuff tendinosis. Calf muscles leading into the Achilles tendon can get affected and very common cause of leg pain. So apart from tendons, what are ligament? Okay, what are tendons? Tendons are those structural parts where muscles get converted into tendon and then tendon attaches to the bone. But what are the ligaments? Ligaments are again the connective tissues, soft connective tissues, which connect one bone to the another. So whatever the ligaments affected in the body, as a pain physician, we do treat those ligaments as well. Commonly affected ligaments are the medial and lateral collateral ligaments of the knee, as well as anterior and posterior cruciate ligaments. Apart from that, commonly affected ligaments in the body are for ankle joint, especially ATFL, that is anterior talofibular ligament, and deltoid ligament. Sometimes the spinal tendons, like posterior spine tendons in the spinal area, can also get affected, and we do treat them with regenerative treatments. And uh, apart from joints, tendons, and ligaments, what forms the what are the component of musculoskeletal system? Obviously, the muscles. And myofascial pain syndrome is very important and most common cause nowadays for the neck pain, which commonly we call it as text neck syndrome because of continuous use of laptops and mobile phones. So commonly affected myofascial pain syndromes are the upper trapezius, mid trapezius, and sternocleidomastoid, and nowadays even pectoralis. And in lower back, the commonly affected muscles are your quadratus lumborum, psoas major, and piriformis. In fact, when the piriformis muscles get affected, the sciatic nerve compression or irritation can occur, and it can present as radicular pain as well. What is important about this myofascial pain? The myofascial pain doesn't only cause the localized tenderness or localized presence of trigger point. When we palpate those trigger points, and even in active, when the patient have active trigger points, there are active and latent trigger points. Active trigger points means those are very painful even at the rest without doing anything. So when patients have active trigger point, that does not only cause the localized pain, but sometimes it can radiate to the other parts of the region. Like when patient have upper or mid trapezius involvement for myofascial, it can radiate to the upper limb as well, and even to the posterior or temporal and parietal region of the skull as well. So, and then coming to the widespread musculoskeletal pain. Among the common conditions which are encountered in clinical practice for widespread pain are inflammatory arthritis like spondyloarthropathies or rheumatoid arthritis. There are various specific diagnostic criteria for spondyloarthropathies and rheumatoid arthritis provided by ACR and ULAR. We just need to identify if those criteria are being fulfilled, and if those are getting fulfilled, then we need to start with the treatment. But not always the presence of rheumatoid or in fact the absence of rheumatoid factor or negative anti-CCP or negative HLA-B27 doesn't mean these inflammatory conditions are not present. So we must always need to find out, we must always need to check with the diagnostic criteria provided by ACR and ULAR whether those can fulfill these conditions or not. Important again, but very misdiagnosed and mistreated thing is fibromyalgia. Though I have included fibromyalgia in the musculoskeletal pain, it is actually a classic example of neuropathic pain. The only reason behind including it under the heading of musculoskeletal pain is that patient usually comes to the doctor with musculoskeletal pain condition like muscle pain, joint pain, and some other some other cognitive symptoms or fatigue or headache and number of things. So again, ACR, again, there is a scoring system for this diagnosis of fibromyalgia. Fibromyalgia cannot be diagnosed with um, any lab test or any imaging test. But again, this is the diagnostic criteria for fibromyalgia, and based on the number of regions affected by pain and other symptoms like fatigue, waking unrefreshed, cognitive dysfunctions like forgetfulness, and presence of other symptoms like abdominal pain, headache, and depression. Based on those presence or absence of those number of criteria, we can diagnose it whether it is fibromyalgia or not. Then coming to next topic, that is neuropathic pain. Neuropathic pain is defined as a process occurring after primary lesion or disease of somatosensory nervous system. So just for the sake of differentiation, we can differentiate them into central or peripheral or combination of both central and peripheral neuropathic pain. So the classic examples of neuropathic pain are CRPS, that is complex regional pain syndrome, where one extremity is involved following trauma or surgery, or sometimes even the trivial trauma that cannot be remembered by the patient. But there will be a combination of symptoms like severe pain, not responding, like not also, which cannot be related with the impact of trauma or surgery. Then there are some skin color changes, nail color changes. There will be hyperalgesia or allodynia, and so these are some diagnostic features for CRPS, again provided by ISP, as well known as Budapest criteria. Based on that, so what happened here, Dr. Vinita had made my job very easy to let you understand about the neuropathic pain. So all those peripheral and central sensitization things can happen over here, and this can lead to severe pain, which is very difficult to treat. So most of these neuropathic pain conditions are not easy to treat. Another commonly affected, and every anesthetists are reading from their postgraduate days, is your phantom limb pain, where there is absence of the limb, but patient still feel the pain in the absent limb. Sometimes there are phantom sensation as well, where patient might feel there is some anklet or some wristwatch is there in the absent limb. That can also be sometimes troublesome to the patient. Uh, Another classic example is post-herpetic neuralgia, where after acute herpes zoster has been solved and the pain still persists over the affected dermatome. Most commonly affected are T5 and T6 dermatomes, and after that V1 dermatome is commonly affected. So what happens? The nerves and DRGs uh, lead to the peripheral sensitization, and after DRG again there is a central sensitization associated with that, and this leads to the severe difficult to treat post-herpetic neuralgia. Another classic example for neuropathic pain is trigeminal neuralgia. Dr. Goel has talked about the trigeminal neuralgia, where your fifth cranial nerve, which supplies to the face, gets irritated because of any cause. It can be primary, or it can be secondary, or it can be classical, it can be anything, but the main pathology behind, in the easiest words which we can say, is the irritation of the fifth cranial nerve that can lead to the severe episodic shock like sensation over the face or forehead. So at the starting of my talk, I was talking about the prevalence of diabetic mellitus in our population. As so many people are affected with diabetes mellitus, many of them usually have diabetic neuropathy. Diabetic neuropathy can classically present as a glove and stocking like appearance, where your neuropathic pain starts with the feet and then gradually ascends up to the knee and hand, like that. But this might not be the always case. Sometimes even the single now might get involved, or there can be involvement of plexus sometimes. So diabetic neuropathy can present in a number of ways. So we need to be vigilant, and we need to check with the patient whether the diabetes is well controlled or not. If the if it is not well controlled, if it is long standing, then there are high chances that patient might be suffering from diabetic neuropathy. Another very difficult to treat neuropathic pain is post-stroke pain, where the patient had the history of stroke, and it may present with pain over the one side of the body, which might include the entire one side of the body, or might include just upper limb or lower limb. It can be anything. Then we have chronic post-surgical pain syndrome, where there are a number of risk factors mentioned here, and those can lead to the chronic post-surgical pain syndrome. The best way being all an anesthetist, how we can avoid CPSP is that if we give very good analgesia in perioperative period, there are lesser chances that patient can land up into chronic post-surgical pain syndrome. So coming to another part of neuropathic pain, where the single nerves can get affected, or these are commonly we call it entrapment neuropathies. The most commonly encountered entrapment neuropathy is carpal tunnel syndrome, where median nerve gets compressed at the carpal tunnel. Apart from those, some cubital tunnel syndrome, or Guyon's canal syndrome, or posterior interosseous nerve entrapment syndrome can present. So what happens when entrapment of these nerves happen at these particular regions? The nerve supplying to that region, like for example, carpal tunnel syndrome, median nerve gets affected. So median nerve supplies to the thumb first and the medial half of the third finger, lateral half of the third finger. So that part of the nerve supply gets affected, and patient might present with the typical neuropathic pain symptoms. But sometimes this is very difficult to diagnose, because not only the entrapment neuropathy can cause distal pain, but it can cause sometimes the pain proximal to the entrapment as well. And we might get confused it with the radiculitis also. Like for upper limb radiculitis, might mimic the cubital tunnel syndrome, might mimic the Guyon's canal, or carpal tunnel syndrome. So whenever we are dealing with the patient, whenever we are taking the history and doing the physical examination, we have to be very thorough with it, to assess whether what the differential diagnosis or provisional diagnosis could be. And based on the differential diagnosis made, we can go for the imaging techniques and other lab investigations. Same thing happens with the lower limb. For lower limb, we have tarsal tunnel syndrome, which can lead to the entrapment of posterior tibial nerve. On lateral side, we have sural nerve, which might get entrapped. Commonly affected one, which can lead to the neuropathic pain at the anterolateral aspect of the thigh, is meralgia paraesthetica. And again, all these conditions can get mimicked with your lumbar radiculopathies or lumbar radiculitis. And coming to the cancer pain. What is cancer pain? Or what causes the cancer pain? Cancer pain can be caused by the disease itself. The inflammatory process going on due to the pathology of cancer can cause pain. Or the treatments which are being used to treat the cancer. It can be anything. It can be surgery or chemotherapy or radiation therapy. Anything can cause the pain. What kind of pain it is? It can be nociceptive. It can be nociceptive pain. It can be neuropathic pain, or it can be both. So disease itself can cause the combination of pain. Treatment can cause combination of pain, like specifically radiation therapy and chemotherapy can lead to the neuropathic kind of pain. Surgery can lead to both neuropathic and nociceptive kind of pain. And when I talk about the disease itself, disease can have compression of the local structures. So the compression of local structures can cause pain, or even the distant spread of the disease, like say for example pancreatic C pancreas spreading into the vertebral, leading to the vertebral mates, that can cause the vertebral pain, and subsequently sometimes can even the fracture of the vertebrae. So anything or everything of these things can be cause of the cancer related pain. So not only the muscles, musculoskeletal system, or neuropathic pain conditions or the cancer pain we treat. Another important area which I thought must be covered is we treat the primary headache, but not the secondary headache. So whether it is primary headache or secondary headache, we should be to diagnose it. We should be thorough with the diagnostic criteria of all these things. The ICSD have given the laid out the very good diagnostic criteria, and commonly affect like common primary headache which we see in our daily practice are migraine and tension type of headache. Rarely we see trigeminal autonomic neurocephalgias like cluster headache, and other primary headache are extremely rare. But yes, we do treat migraine and tension type headache, and we do really encounter them on a daily basis. Not only that, sometimes the important secondary cause of primary headache are cervical facets or occipital neuralgia. So these kind of pain are also being treated by pain physician. We just need to be vigilant about the cause of pain. Once we understand the cause and pathophysiology of the pain, the treatment is not that difficult. So how do we treat it? We treat conservatively using drugs, advising patients on physical therapy or occupational therapy. We might need to have we might need to take the help of our psychiatrist or psychologist for the treatment. And sometimes we need to cross refer the patient to other specialists like neurologist or neurosurgeons or orthopedic surgeon, depending on the situation. And what we specialize in, we specialize in minimally invasive pain and spine intervention. That is MIPSIS, a very well known word provided by Indian Society for Study of Pain. So we do a lot of MIPSIS, and what kind of basic or what kind of MIPSIS we use? We use image guided, like sonography guided, or CM guided, or even CT guided injections. What these are advanced injection where we use some many of the times steroids or chemical neurolysis with alcohol or phenol. Nowadays we are using regenerative therapy very commonly, which includes platelet-rich plasma or growth factor concentrate, and now slowly we are moving with bone marrow aspirate concentrate. We sometimes use prolotherapy for tendinopathies. We use hydrodilation of the shoulder. We use hydrodissection for the intrapatient neuropathies. We do use radiofrequency ablation and cryoablation, which is coming gradually, but radiofrequency ablation is being used for n number of conditions, including musculoskeletal, neuropathic, and cancer pain. And some advanced modalities which are still not very common in India but have very bright future are neuromodulation like spinal cord stimulator or peripheral nerve stimulators. So to conclude for postgraduates, it is important to know that chronic pain is itself an entire universe. It's a very big topic, and to understand and learn the chronic pain, you need to dedicate a proper time for it. It's not a part-time job to learn the chronic pain. We need to be thorough with history taking and examination, the art which might get unlearned during the anesthesia postgraduate training. And we need to investigate the patient based on our history and examination findings. We have vast array of treatment to treat this kind of condition, but understand you need to learn it in a hard way in a structured teaching learning program. Thank you.
Thank you, Dr. Tople. As you rightly mentioned, chronic pain is a totally different entity, which most anesthesiologists may not be entirely familiar with as compared to acute pain. So thank you for making this topic very simple and easy to understand for the postgraduates and practitioners. We move on to the next presentation. I request you to stop sharing the screen. And it is another important topic on the role of ultrasound in chronic pain diagnosis and management. And to present this topic, we have a distinguished speaker, Dr. Rajendra Sahu. He is MD CIPS, ESRA PMUC, and has fellowship in pain medicine from University of Toronto. Currently, he is associated with the KIMS Hospital in Bhubaneswar and is the director of Neuron Pain and Spine Clinic Bhubaneswar. His area of interest include MSK ultrasound, neuropathic pain, and pain education. He has several publications both in the journals and as book chapters, and he received the Best Research Award at ISSP National Conference and Best Innovator Award at the same conference as well. Thank you, Dr. Sahu, and I request you to please share the screen and start your presentation.
Yeah. Good evening, all of you. Thank you, Dr. Sri Ganesh, for the wonderful introduction there. First of all, let me thank you and the College of ISA for taking the initiative for this wonderful academic event. We have already 4 lectures, and I thank all my previous speakers for covering the very pertinent topics on the pain medicine. So, moving to my topic, so this is all about the ultrasound in the diagnosis and the treatment. So, greetings to all of you from the KIMS Hospital. This is a deemed university hospital in Bhubaneswar, and from my clinic, Neuro and Pain and Spine Clinic. Okay, so in this lecture, so what I'm going to do in next 20 minutes is recognize the broader role of the ultrasound in the pain medicine, how ultrasound helps in making accurate diagnosis. Actually, that is what we do in the pain clinic, and how it is helpful in doing precise interventions. Now, I'll take all of you through a few real-time, real-life, real-world case scenarios that we come across in our clinic on day-to-day basis. Okay, why this is not moving? Okay. So pain medicine, like suppose when I started in 2019, it was more of spinal pain in OPDs, some of the trigeminal patients. And now in 2019 or 2025, look how people are engaged with smartphone instead of, spending time with family members. Similarly, in those days, it was fluoroscopy, laid up runs, wait for the CM, lack of proper OT hours. If don't have specific OT times for the pain physician, you just wait for the orthopedic neurosurgery to finish the OT, and you do at the odd hours and plenty of radiation exposure. So now pain medicine is not only to the spinal pain, although we see a lot of spinal pain patients, we see plenty of MSK pain conditions like knees, other musculoskeletal conditions, sports injury patients, regenerative medicine, neuropathy. This has all changed thanks to the ultrasound. Okay, so we have been doing it because of the ultrasound, and ultrasound is the stethoscope now. That how it is, I'll take you through all these case scenarios. Let me start with what ultrasound has made. It has made common and uncommon conditions diagnosis very clear and precise. It helps in decision making. Actually, in the clinic, if you have a machine, you can put it over the shoulder, elbow, knees, feet, or the wrist, anywhere you see the nerve pain, anything, you can just confirm the diagnosis, or you can exclude something. Okay, and you can quickly make a diagnosis. You can avoid certain costly investigations like MRI or something like that. It helps in doing interventional procedures, like procedures which are unthinkable without CM, that you're able to do without CM also. Bedside procedures, it can help in safe, accurate, and efficacious performance of the procedures. Let's start with case 1. So this is a 72-year lady, chronic shoulder pain, so inability to do overhead activity. It came to me with a diagnosis, the bunch of paper. She has been having this pain for more than 2 years. She has seen multiple of doctors, plenty of orthopedic, neurologists. They all branded as a periarthritis shoulder, or frozen shoulder. She was, of course, diabetic, hypertensive, thyroid, osteoporosis. And one surgeon even gave, typical the landmark guided corticosteroid injection. It didn't help at all. She came to me. Okay, I just did a bit of physical examination that gave me enough clue and put my ultrasound probe over there. Have a look at this video. So this is a long axis scanning of the supraspinal tendon. Can you see this hypoechoic defect there in the long axis scanning? So which shows a full thickness tear of the supraspinatus tendon. Okay, there's a bit of tendon there. There is no tendon at all. Okay, full thickness tear. As I move to the second video, which is a short axis scanning. Okay, look at this video. So you can see a broad, full thickness and almost a full width. Can you see this thickness, full width of this is what width we see while doing a short axis scanning over the rotator cuff. So the diagnosis was clear. This was a full thickness supraspinatus tear. In fact, she was not able to do overhead activities actively. The moment I did a passive abduction, I was able to achieve almost 150 degrees of abduction. The moment I dropped the shoulder, it was falling down. That was the drop arm test positive. So this was diagnosed, branded as a frozen shoulder by orthopedic people, 4 or 5 orthopedic people, neurologists, or the physicians. Whereas it was a full thickness supraspinatus tendon tear. So that means, and this chronic tear, and that stump was also retracted when I did a MRI. There's something called Gutelier classification. There is grade 3 atrophy of your supraspinatus muscle, making it a inoperable case for the rotator cuff surgery because there is a high risk of re-tear again. So this was missed diagnosis, and the lady was suffering. Okay, Let me go to the next case. Okay, another lady. I see a lot of shoulder patients. 70-year lady with chronic shoulder pain, bilateral shoulder pain. Of course, all those lifestyle diseases. She had diabetic hypertension. Again, she a lot of doctors branded as frozen shoulder. Came to me so very recently, maybe a month or 6 weeks ago. Have a look at this. So she had bilateral. So this is the right side shoulder. I did a short axis scanning here. This is the biceps tendon. You can see a lot of subacromial bursal fluid. Can you see that? Okay, so this is the deltoid muscle there. There's a bit of floppy thing. Those are the synovial hypertrophy there. When you see this amount of synovial hypertrophy and the subacromial bursal fluid, you need to rule out a only thing that comes to your mind is probably highly likely a rotator cuff here or can be a rheumatic condition. Okay, and then I did a scanning or long axis scanning. You can see here this is for the supraspinatus tendon. I'm seeing the biceps tendon. Look here, there is no tendon at all, complete nothing at all. Okay, so that indicates a full. So this is short axis scanning. You can see that cartilage interface sign there. There is deltoid muscle. There is nothing, full of fluid there, no cuff at all. This is a full thickness, complete tear of the supraspinatus tendon. When I did the right side, if you had seen those two videos earlier, have a look. This is the left side shoulder. I can see had pain over the left side. This is the supraspinatus tendon. As I play this video, can you see there is a full thickness tear? This focal full thickness tear at the attachment side, and the tendon is intact there. Okay, so this is something called partial width full thickness tear or a focal tear. Okay, the other video that was a complete full thickness and full width. This is short axis scanning. Look here, I'm just pausing here. You can see this full thickness from dorsal to the articular surface, but posteriorly tendon is intact. This is just so this is a biceps tendon. So the anterior focal full thickness here was there, this on the other side. Whereas this lady again has been branded as a frozen shoulder. So the point of these two videos was that there is so much of misdiagnosis when the shoulder pain comes. Actually, a lot of physicians they go to orthopedic neurologist or the orthopedic. They typically write PAS, periarthritis shoulder, the frozen shoulder, something like that, or maybe into cardiologist for a lot of cardiac conditions, shoulder pain, or the endocrinologist also. Okay, because of the diabetes, they do have a shoulder pain. Not all of them have frozen shoulder. Quite a good number of them have this cuff tear, which is undiagnosed or misdiagnosed. So how do I diagnose this rotator cuff accurately with ultrasound? If you follow a stepwise scanning protocol, and there are certain criteria also. If you look here, there is a volume loss, there is a cortical irregularity. Look here, you'll have a cortical irregularity here. Volume loss means like the cuff is that thickness is less. You can see a subacromial bursal fluid like last video, joint fluid, deltoid herniation. There will be anechoic defect. Look here, these are the defect here. I'm showing with my cursor here. So these are the certain signs for a shoulder tear. So these are the indirect signs like fluid around the biceps tendon, fluid around the joint, and the subacromial bursal fluid. Okay. Ultrasound helps in diagnosing the etiology. Mind it, this is again another patient with the shoulder pain, and again it's sent to me from our rheumatology colleague, very VIP person. Okay, treat this person with shoulder pain, having there for quite some time, maybe more than a year or two. He doesn't have diabetes. So when I examined, I could do a almost 120 and 130 degrees of passive abduction, which I thought, okay, this is not a definitely not a shoulder pain, not a frozen shoulder. External rotation was almost preserved. But ultrasound probe, what I found that there is this, the long axis scanning, there is a shadow there, okay? And this is on the short axis scanning also. So this is a calcific tendinosis, okay? Supraspinatus calcific tendinosis, whereas this was branded as a rotator cuff tendon. See, with just in the clinic with ultrasound, within just a minute or two, the diagnosis is clear. I don't have to do any MRI, any fancy stuff also. You can spend, save money, you can save time also. What I did next was a barbotage, okay? So this is what, you do it here. I put a bit of local anesthetic and then put a 16 gauge needle inside that calcium there, that hard calcific tendon there, calcification. And as I go inside, okay, I try to rotate that, okay. I try to rotate that needle multiple times. Sometimes you may feel it very hard to go inside the calcification, okay. So once you do that, we are able to do that, take 5 ml or 10 ml syringe and then inject a bit of saline, okay. Inject, try to inflate that. And if you're able to break it, and then you can aspirate that chalky white material also. Sometimes you may not able to do any. Look here, I'm injecting a bit of saline here, okay, that you can see a bit of expansion there inside that calcific tendon, and I'm aspirating here the bit of chalky white material. Okay, once you end it, don't forget to finish that case with a subacromial bursal injection is a must. Okay. Moving to the next, another very interesting case here. This lady came to me recently with lateral elbow pain, and believe me, in one of the peripheral location, the district area, the orthopedic surgeon gave her cortisone injection one every week, 5 times. Every time it helped for few weeks. Okay, and then the patient came to our one of our orthopedic surgeon, and he referred the patient to me. Okay, the fellow with me told she was quite enthusiastic, sir. This is a case for the PRP. Okay, I scanned what I see here. Look, have a look at here. So there's a complete tear. There's a tear of the common extensor tendon, and a bit of this is not covered. And this is the radial collateral ligament. The radial collateral ligament was also torn. Okay, so just for information of others, so this is how a normal tendon looks like. This is the lateral epicondyle, this is the radial head, this is the radial collateral ligament. You can see hyperechoic tendon there, but in that case, look here, the arrow mark, there is a complete tear. This necessitates surgery. PRP is not going to help. So this is how this blind injections can cause damage. Blind repeated steroid injection in tennis elbow. We do not do any cortisone injection these days. We do PRP. Okay. Ultrasound also helps diagnosis of uncommon conditions. This is a patient with a known knee osteoarthritis with medication. His knee pain was better, but came to my clinic with severe, just kind of few days onset of lateral knee pain. Okay, like lateral knee pain, severe, limping gait. When I examined, of course, I had those X-ray images. I saw that is okay, grade 2, grade 3, early grade 3 osteoarthritis. When I scanned, can you see that on the lateral side? This is your popliteus tendon. This is your meniscus, and the top of the meniscus there is a cyst. So that was a parameniscal cyst. There was severe tenderness over the cyst. Okay, the patient, the pain, acute aggravation in the pain was from those meniscal tear and the parameniscal cyst. That helped in the diagnosis, and with bit of aspiration and injection, that acute pain got subsided, which was not getting subsided with very high dose of NSAIDs and even tramadol also. Coming to the next case, very interesting. Very interesting. If you're listening, pay attention to this. So this is a lady, this is a gentleman actually, referred to me from the orthopedic OPD. Okay, this is a 50-year gentleman who had a RTA and underwent from the distal radius surgery with a plating there. Okay, and following that surgery, few weeks later, he developed tingling paresthesia, electric shock type pain over the lateral 3.5 fingers, typical of a carpal tunnel syndrome, electric shock type pain. Okay, went to the same orthopedic people. They did a nerve conduction. They told it's a carpal tunnel syndrome. Okay, nerve conduction. Okay, what they did, a surgery, carpal tunnel release. But unfortunately, following the surgery, there was no relief at all. They kept on giving medications, up to 300 milligram of pregabalin, tramadol, then amitriptyline, duloxetine, whatnot. And then because it was not getting relief, they did a cervical spine MRI to see if there is any pathology proximally. So it was also normal. Cervical spine, brachial plexus, everything was normal. Then they sent to me. Okay, so I did a scan, and what I found is very interesting. So what I saw, that if you tap at the proximal part of the scar, the patient experiences severe electric shock pain to the going to the 3.5 fingers, typical of a median. It was a median neuropathy, but not necessarily compression at the carpal tunnel. Okay, so when I did a scanning, let me play this video. Look here, that white arrow, that is the median nerve. How big is that at the distal forearm, where the this is the nerve. This is the nerve. As I go, you can see a very hyperechoic swollen. Can you see so much of changes in the nerve? Those who do proximal scanning of the forearm, you can go and see how does the normal nerve look like, and see the big swollen nerve actually. So this was the nerve neuroma at the proximal scarring from the previous plating surgery, not recompression from the carpal tunnel actually. So what I did dextrose prolotherapy. I went with the needle. See here, until I'm trying to, because of so much of compression, so much of entrapment is there, is kind of rolling over. I'm trying to break that adhesion. So I did with around 12 to 12.5 to 15% of dextrose. 3 times I did, every 2 weeks, every 7 to 10 days. I did 3 times. What I was able to achieve was around maybe 40% of maximum relief. I also increased the dose of neuropathic medication. So that was the limitation actually. So I did both above, and this is below, also below the nerve. I went there. I just did that. I did dissection and release with dextrose prolotherapy. So that was the thing. So thing is that this person one could have avoided a carpal tunnel surgery had there been a little cooperation from the surgeons. An earlier referral before doing that carpal tunnel surgery would have been better actually in this patient, because it was a clear-cut case of not a carpal tunnel surgery but from the compression from this surgical neuroma there. Moving to the next case. Okay, this is again another interesting case also. This lady, a 33-year-old lady, came to me with a radial head, lateral epicondyle area pain. Okay, pain over the lateral epicondyle. When you think of that, the first thing that comes to your mind is a lateral epicondylosis or the tennis elbow. Okay, so typically the patient will have pain over the activities, doing all those kitchen works, cleaning the house, still feel tired. Not only pain over that area, over the bit of radial head, and sometimes goes to the forearm, distal forearm with bit of tingling, some neuropathic pain characteristic also. Went to orthopedic. Okay, they did a lot of medication also, and the orthopedic one orthopedic people told is a brachioradial strain. Other people, because it was next to the lateral epicondyle, gave a PRP. That didn't help anything. PRP, nothing helpful. Brachioradial strain, medication, nothing was helpful. Then another orthopedic, he sent to me. Okay, it's a senior orthopedic, he sent to me. He told me probably looks like a posterior interosseous nerve syndrome. Have a look at it. How does it look like? Okay, so when I scanned, this is what I found. Okay, this is a short axis scanning and this is a long axis scanning. So there is a cyst, and this is the nerve, radial nerve. Before just about, this is just closing to the radial head. I'm coming about to divide into superficial and deeper. It is almost divided, and there is a big cyst. When I scan the long axis, you can see this is the radiocapitellar joint. This is the multiseparated cyst that between the brachialis and the brachioradialis muscle and close to the nerve, compressing the nerve actually. That is the reason she was having a bit of neuropathic pain characteristics while doing all those activities. So with this information, I sent the patient for an MRI scan, and the report came out exactly the same. And I sent back to the same surgeon who had referred to me, and they did a surgery, and patient recovered and did well. So these cases, they highlight the importance of doing a musculoskeletal ultrasound in the OPD and the role in accurate diagnosis and avoiding unnecessary tests, and prolonging the suffering of with and kind of bad diagnosis also. Okay, so this is how when a PIN entraps, you can see big swollen posterior interosseous nerve there also. Okay. Pardon. Next case. So this is a gentleman, again, another employee in our hospital. You can see in the lateral leg. So he had an AVN, young guy, 35-year gentleman. He had an AVN. See, he got core decompression and some fibular bone graft also. So for a few weeks later, he had severe electric shock type pain going from here all the way to the dorsum of the foot. So tinelcine was positive, sonotillin was positive, medication was making him drowsy. Lyrica, he was taking something 75 BD, some tramadol also was making him drowsy, sleepy, nauseating also. So he came to me. What I found is a big superficial interment neuropathy from that scar area itself. So this is so interesting. This patient, I again did a dextrose prolotherapy, 12.5%, 2 sittings, complete relief now. It has been around more than close to 3 years actually. So this is under publication now. Next interesting case. So this is a 40-year lady who had abdominal pain. You can see exactly pointed pain over this area of the abdomen. Okay, constant daily pain over 3 years. Last 6 months, pain got aggravated, typical of neuropathic character, 7 to 8 in NRS, hypothyroid, obese patient. Between 2004 to 2015, she had this many surgeries. Okay, and in fact, she underwent this lap adhesiolysis recently because of her persistent abdominal pain. And no wonder there was no relief. And she had done, because her husband was a pharmacist, she had seen almost pretty much almost every doctor in the city of Bhubaneswar and Cuttack, all kind of tests. They have done MRI, CT, anything you just talk about. There's a little bit benefit from Lyrica and tapentadol, but again, the side effect from drowsiness was affecting her. Came to me. So I did few tests, I did no test actually, because everything was done so far. So I found the examination, there's a tenderness, there's a CARNET test which is positive, there's a tenderness with sonography also. So I thought the diagnosis acnes, anterior cutaneous nerve entrapment syndrome. So what exactly is acnes? Acnes is basically there's a small nerves, thoracoabdominal nerve, that travel in the TAP plane. We all do the TAP block, and they approach this lateral part of the rectus. They take a 90-degree course there and become superficial. That is anterior cutaneous nerve. That is what it gets entrapped. So what I did rectus sheath block. Okay, take to the in the OR itself. I did twice actually. First one I did with lidocaine 30 minutes, pain is vanished. So lasted for 2 weeks. The patient came back again. I did with BP hacking with bit of steroid next time. Again, to relief of pain relief, 2 weeks of pain relief, and came back to me. No medication in those 2 weeks. So that confirmed again my diagnosis of acne. So what next? So what next was like I did alcohol neurolysis next time in the OT. 50% alcohol slowly I gave. Not much of relief, like 3 weeks, 1 week extra compared to those local blocks. So the next thing that came to my mind was RF ablation. You can see this RF cannula over there. This is my big fat lady. You can see 4.9 centimeter here depth. So that is rectus sheath. This is the RF cannula going there. So this is a nice feedback. The gentleman, the husband is a pharmacist. He wrote this feedback. So first RF ablation, she had complete relief for 11 months. Okay. And then I repeat the RF ablation and lasted for 18 months actually. So now again, recently came back. I did load, kind of low intensity of the pain. I did another tap rectus block there that helped her. So acne is basically the nerve entrapment of those thoracoabdominal nerves, and they can get entrapped here. Lateral border, as you told here, has to go there and get entrapped here, leading to this pain. Believe me, the surgical community, gastroenterologists, they're not aware. Most of them are not aware of this entity as a cause of the pain. We all are obsessed with the visceral cause of the pain. We just forget or omit the abdominal wall as a source of the pain, out of which this contributes to around 15 to 20% of the patients. So we need to keep this in mind. And the eye sees what the brain knows actually. If you just know, you can suspect, you can go for these diagnostic blocks. Okay, so this was our paper on those subject, and this is again the RF ablation again will come up very soon also. Okay, so I have a few minutes. I'll just finish quickly. Dr. Kamath there, he was looking at me just to finish it.
No, no.
Okay. Okay, so ultrasound now with that bit of I covered bit of diagnosis. I'll just quickly cover up the intervention. Ultrasound helps in office-based procedures. It helps in doing advanced spine intervention and also the bedside procedures. Look here, this is a procedure, a transforaminal epidural, or it's kind of paraforaminal, the block for the cervical radiculopathy. You have a disc herniation going to the C6, C5, or 6, 7. So in early 2000, a lot of patients, they had this neurological complication from the particular steroids. Then the procedure got a negative recommendation. It was vanished. Nobody was doing that. And then recently there is resurgence in last 5-7 years, because we are doing that with ultrasound, or kind of hybrid technique, where I can go exactly with put my needle there next to the foramen, just below the nerve, can bit of hydrodissect and see that there is no blood vessel, and put a dye, and then see that. So ultrasound helps. This is how you can do it. This is what we do. This is a C5 level. Both anterior and posterior tubercle at the same height. You can go down C6 and C7. Okay, so sympathetic blocks we do for various sympathetic pains. So that is typically done with fluoroscopy guided. Now there is enough literature also, and people are doing also with ultrasound assisted, that can be confirmed with fluoroscope. Here you can, if you know how to do a QL block, or kind of, so that way you can put a needle and just below the anterior fascia of this was, and once you reach there, check with the fluoroscope, give some dye there. It's AP and lateral. So that is a lumbar sympathetic block for all those vascular pain or the CRPS type pain also. Ultrasound helps in doing a bedside procedures for a lot of cancer patient cannot be moved to the procedure room, or kind of a lot of ascites, severe pain, they cannot be made prone because of the abdominal pain. So you can do the ultrasound guided celiac plexus block in the cancer patients also. So I don't know if anybody does this stellate ganglion block these days, fluoroscopy guided. 2010-11, we were doing all those fluoroscopy guided. If you just know now, I'll be scared actually. I won't do that actually. Looking at so many literature and doing so many blocks. In the vicinity of so many things, you have big blood vessels, abnormal blood vessels, you have trachea, you have nerve roots, you have so many other things. But you can end up with complication at any time. Actually, you have esophagus. So ultrasound helps in safely doing these procedures quickly. In OPD, I do this stellate ganglion blocks in the OPD office-based procedure. 3 minutes will be done. Okay. By the moment I'm just washing my hand, patient coming out, you'll see good Hermit syndrome also. Okay. So that helps in. So nowadays, coming to the next and final part, the hydrodissection, that is for a lot of neuropathic pain that we do. we do in the OPD based. So one of the common intraoperative neuropathies is CTAs, we have neuralgia, tarsal tunnel syndrome, and so much. So ultrasound, we have diagnostic criteria now. Okay, it is equally sensitive or even more effective. We can pick up etiology. Any tenosynovitis, any hardware, any inflammation like RA in the joint that compressing the nerve. So we can diagnose that also. We can do a short and long axis and scan the nerve, and we can do hydrodissection here. So this is how it is done. So you can see this is kind of median nerve compression. This is my needle coming from the ulnar side. So these are the tendons. This is the pulsation, the radial artery on that side. This is your FCR tendon. You can see here. That is my needle going there. Flexor retinaculum on the top. So I'm going slowly advancing my needle. This is the epineurium actually. One need to be careful not to breach the epineurium. And the needle has to be just below the deeper most layer of the flexor retinaculum also. So I go to that side. Once I'm done, so I go to the inferior of the nerve, so to complete the hydrodissection. Look here, these are the tendons, flexor tendons and the tendon sheath. So sometimes you may end up injecting just below the tendon sheath also. That needs to be carefully done with very, very fine. You can see that very nicely how the tendon sheath and the nerve epineurium getting separated. So ultrasound has a lot of advantage, cost, portability, is patient friendly. You can interact with this patient, no contraindication with ultrasound, high resolution. You can reproduce, you can follow the patient in the subsequent visit if there is regeneration, how is the flow. Compare with the contralateral side, which is not possible with MRI. Okay, and Doppler, you can use the Doppler to screen for the inflammation vascularity. Only disadvantage is operator dependent. There is a learning curve. Of course, there is a learning curve with everything, but this is a wonderful tool to learn and master it also. So how to gain proficiency? You have to be very, very thorough with your anatomy. Learn under a mentor. Okay, you can find a lot of YouTube videos. There is so much information, but in the beginning you may get lost. Actually, you may find it difficult unless you know it. So it's always good to learn under mentor. I was fortunate to learn under Dr. Philip Ping and other people at Canada. Scan a lot with a lot of normal individuals. Scan each and every patient. Attend courses. Keep learning, and then follow a protocol. Okay. So thank you very much for your patient hearing. I finished exactly in 22 minutes. Thank you.
As usual, Dr. Sahu, excellent presentation with practical day-to-day scenarios and real-life situations. So very well done. I think there are a few questions for you. It would be nice if you can answer them so that we can save some time and move on to the next presentation.
Okay, I'll check that
Okay.
in the, I'll stop
Yeah, there are
sharing
some
here.
questions in the chat. Maybe you can reply them there.
Okay.
Okay. Yeah, and if required, we can discuss at the end. So
Okay.
we'll move on to the last presentation. And those of you who are staying so late in the night, I'm sure are interested in chronic pain and pain as a specialty. And Dr. Amitesh will be discussing about the SWOT analysis of pain medicine as a specialty. He is PDCC in pain medicine from Banaras Hindu University and currently working as associate professor in the Department of Pain Medicine and Palliative Care, Integral Medical College, Lucknow, and is also the director of Sahaj Hospital, Lucknow. He has numerous publications and his area of interest is advanced endoscopic spine intervention. Over to you, Dr. Amitesh Patak, and sorry for keeping you waiting for so long.
It's fine, sir. I'm not able to share my screen. There is some open system settings which is required.
You're not able to share your screen at all?
No. It's written to share your screen. You allow screen recording for Chrome in system settings. You then need to restart the Chrome.
Let me check whether you are a co-host. I think, yeah, you are a co-host, so you should be able to share. Or you can send it to me and I can share the screen and you can speak. Is that okay?
Yeah, I think that's good.
Not able to open that.
Dr. Amitesh, if you're not able to share, please send that PowerPoint
Yeah.
presentation to me so that I can share from my end.
So it's in the laptop.
No, you can share it with Dr. Ganesh. Ganesh.
Unfortunately, we are having technical issues today, so I think we need to do a trial before.
Sir, can you tell me your email ID?
No, we are not seeing your screen.
Shall I mail it to you?
Yeah, mail or even put it in the group, WhatsApp, or personally to me, no issue. Dr. Rajendra, meanwhile, you want to take up the answer those questions? Possible?
I'm just reading actually. I'm reading the chat box. Maybe
Sure,
I'm
sure,
yet
sure.
to go to my questions actually. Their
Okay.
questions indicate
They are towards the end.
Last few questions.
So can I
Yeah.
have your email ID?
last 3 questions.
Whether you can use ultrasound for transforaminal epidural injections.
Okay. Okay. Well, there are descriptions and there is, way how to do it also. But we do not do that in routine practice actually. Very few people do that in routine practice. It is so easy to do that with fluoroscope. So all those spine procedures has basically ultrasound assisted, and you definitely end up with fluoroscope and give a dye study also. But I do that with exclusively fluoroscope guided. It can be done also. It can be next to the periodicular also. I have tried once or twice, but then I do it fluoroscopy guided, and it's so easy.
True. The next question is regarding your blog. How did you identify or localize the dermatomal distribution of pain? Because these are facial blocks in the first instance, and then you did radio frequency ablation as well
Okay.
for the
So
intracutaneous
thing
nerve. Yeah.
Okay, thing is that yeah. So Nitika Goyal has written. So if you look at the if you next time when somebody Nitika has asked, na, if you go and scan that erectus sheath block also, the lateral third area, the anterior cutaneous nerve takes a 90-degree curve. And there one can visualize a hyperechoic fascial like expansion, that area actually. If I can, oh, I deleted that slide. Actually, I had that slide because it was too many slides. I deleted. So one can. So let me tell you, when I was doing the RF ablation, I got bank at zero point 0.3 volt. I got exact reproduction of the pain because my cannula was next to the nerve itself. When the patient came for the subsequent one, I was little away from that, maybe a centimeter or so. It went up to like 0.7, 0.8 volt to get that stimulation actually. So if you're next to it, how to get that? You can see that bit of hyperechoic fascial line around, taking around 90-degree course also. Try to scan and identify also, so you can find that, if you're next to it, because the nerves they travel around 1 centimeter or 2 centimeter away from each other, like each dermatome, like T10, T11, T12, like that. So exactly pinpoint tenderness, and if you want to be precise, that is what you have to look for, that hyperechoic fascia, and try to go a little scan up and down to find that exactly location. If you're able to get it at very low voltage, then you are next to the nerve actually. But while doing those diagnostic blocks, you don't have to actually, those you give around 5-10 ml of local anesthetic that spreads over. Diagnostic blocks, you exactly don't have to be precisely bang on the nerve, but when doing these ablations, you have to be, it's better you are next to the nerve. The long lasting relief will be there. Yeah,
Okay.
I think, yeah, that's it. I think I can just check out.
Yeah, I think these are the questions for you. I don't see any more. Maybe
Yeah.
one suggestion that ultrasound may be must for any undiagnosed musculoskeletal pain.
Advanced tier of supraspinatus tendon, any options other than surgery? Yes, of course, he can do a simple joint cortisone injection that helps to some extent to some certain group of patients, not all of them, but he can definitely do a articular branches radiofrequency ablation. So the radiofrequency ablation, the cooled RF that has been described for all those small articular branches are basically for the two indications. One is the advanced osteoarthritis, those who are not keen to undergo surgery or kind of high risk for surgery, and also those rotator cuff tear where they cannot undergo surgery, persistent pain. So those are the two indications.
Yeah. Thank you.
And yeah, my friend
So,
was telling also they do at Australia also, they do the suprascapular nerve block, that helps for a few weeks to a month or two, or kind of pulse if that somebody can try, but I have not tried doing that suprascapular nerve block for all those cuff tears. One can try that also. Suprascapular nerve block, which is quite easy to do, and can do a pulse tariff all that nerve also.
Right.
thank you.
Yeah, so thank you, sir. Thank you, Dr. Sri Ganesh, for this wonderful webinar. It was pleasure here.
Yeah.
If you don't mind, I can check out. I have some
Yeah,
work
please,
actually.
please. Thank you very much. Dr. Amitesh,
So-
maybe you can do the presentation without the PowerPoint. Is that okay?
Yeah, it's fine, sir.
Yeah.
I'm really sorry. I think there is some problem with this.
No,
So my,
you can present the thing. That's all.
okay, fine. So my topic is more of a practical thing rather than the theoretical one. And this is a SWOT analysis for the pain medicine. And it reveals that pain medicine is an industry which is strengthened by its multidisciplinary approach and embracing the technology, but it is facing hurdles with the public perceptions, and there is more dependence on the outdated practices. So the growing awareness is a major concern gradually, but there is significant shift in how pain is perceived socially. Traditionally, the chronic pain, when it was not visually apparent, was often dismissed. But now, since there is a growing recognition of pain as a medical concern, so it requires a proper intervention rather than a mere endurance. So the freedom from pain is a basic human right, and now every patient wants to be pain free, and that's very correct. That pain should be, patient coming to an OPD should be free from pain. So the patient's expectations are changing nowadays. Initially, the treatment of pain typically involved around the analgesics, which were more with the physical exercises and physiotherapies and all. But nowadays, a subset of patients either they don't respond to these medicines or they stop responding to these approaches, and they always seek for better options. So many a times we come to a situations where the patient is in chronic pain, and patient is not willing to go for a surgery, or they want to have they want to delay the treatment, or they want to have a second opinion, or they want to have a non-invasive technique. Then there should be some mode of treatment modalities which are more than the medicine but less than the surgeries, which should be given a priority to the patient. So the demand of pain management solution is increasing. So why? The reason why it is increasing, because there are some lifestyle changes nowadays. India is an aging population, and we are getting more urbanized and sedentary lifestyles. All of these are leading to have a many more chronic painful conditions. As the life expectancy is increasing, the incidence of age-related changes and the degeneration of various joints are also increasing. So all these are leading to more of a knee pain or a spine pain or musculoskeletal pain, or all of these are a very painful condition, and everyone wants to get rid of that. So pain medicine has been evolving, and our understanding of pain has been deepened significantly. From earlier, there was a simple linear model of pain is having, if a patient is having pain, it was mainly due to a tissue damage. Nowadays, more complex gate theories are coming into picture, having a multi-dimensional experience. And for that, holistic pain management approach is favored than the traditional treatment with mere analgesics. So now we are, as Dr. Rajendra Sahu had shown, we are using ultrasound, we are using fluoroscopy, and we have precision guided treatment available like ultrasonography or fluoroscopy. We are doing many more minimally invasive interventions, like we are doing radiofrequency ablations, epidural catheter, we are putting spinal cord stimulator, we are putting intrathecal pump. I'm very fond of endoscopic disc decompressions and regenerative therapies. All these are advancement in the interventional pain medicine, which are more target oriented and they have an improved outcome. Also, there is more awareness of the economic and the health insurance penetration coming into the pain picture, and more Indians are having more financial means to seek specialized treatment which is beyond the painkillers. So if we go with the current pain care delivery landscape, what is there in India? So majority of the Indian scenario, if you go over that, pain management care are remained fragmented. There are some larger hospitals who have a very dedicated pain department, but they mainly focus on the cancer pain treatment only. So the specialized care for the chronic pain is very limited. Over the last 15 to 20 years, the pain clinics are there in the major bigger cities, like 10 to 15 pain clinics are there, but still going to the B2 cities or B1 cities or beyond the major cities, the pain clinics are very less. But if you go with in comparison to other specialties like ophthalmology, dermatology, dental, and the dialysis and all, we do not have any national or regional pain clinic chains available in India. So this has to change. So before reaching a pain physician, a patient has to navigate a complex journey of various clinicians. Then only the patient comes to a pain physician. So what we get actually in our OPD are the left ones. So patients find themselves either heavily dependent on analgesic. Many a time they want to avoid the surgeries due to fear, or many a time they are forced to live with the persistent pain because no one is giving them the options of the non-invasive techniques. Many rely on the isolated endless physiotherapy sessions that provide a limited relief, and studies have shown that 60 to 70% of the chronic pain patients, they continue to experience significant pain despite years of treatment. So all of these leading to a further economic burden on our society, on the patient as well as on their family, because they are forced to skip their job because of that. So very recently, the pain medicine has started being recognized as a specialized discipline, and dedicated pain management courses are now being available throughout India. We are having a 1 year course or a 2 year course. FNB are also starting. Even we have a DM course in our country, and the pain physicians are increasing in number. So, but what are the challenges in the Indian context is the main challenge is awareness. Awareness among the patients, awareness among the healthcare providers about the specialized pain management options and the availability of the non-surgical interventions. There is also lack of awareness among the institution to give priority to pain clinic or the pain management, to give it a priority. What are the weaknesses? Weaknesses are that we are shortage of specialists, not handful of more than 400 or 500 pain specialists are there. There is always a misconception and stigma that the pain physicians are the people who put injections or they are going to do needling thing or something like that. And there is always a low brand recognition because we are not much in numbers. Another thing is evidence-based practice concerns. Some practitioners perform procedures without the sufficient evidence of that. And there is always a failure of transparency in communication with the outcomes. Like, you know that in knee pain or osteoarthritis knee, you know that osteoarthritis knee, total knee replacement is the best option available. You cannot falsely say the patient that whatever you are going to do, whether it's an RF or a PRP or anything, what you are going to do is going to permanently heal that that osteoarthritis of knee. You have to be transparent in your communication about the outcomes of whatever intervention you are going to do. What are the opportunities we have? There we can have an integrated care model. We could establish a multidisciplinary pain center. We can form a well-designed pain management center that could involve the specialist consultant, the physiotherapist, the psychological support, and the minimally invasive procedures that you can do with a superior outcome. Then you can have a telehealth consultation. AI-assisted diagnostic tool can be used. So the path forward is for the healthcare providers is to embrace the multidisciplinary collaboration, interdisciplinary collaboration, update your knowledge. For the insurers, expanding the coverage. For the investors, identifying and supporting the innovative models that can address this massive healthcare gap. And for the policymakers to integrate pain management into a national health program and establish a standardized protocol to ensure quality care delivery. So specialized pain clinics are concentrated in metro cities only, and there are a vast majority of population who cannot access this comprehensive care. There is a relatively very low penetration of health insurance in this. So there is scope of all these. There is scope of integrated care model. Regenerative medicine is a new challenge which is must come into picture. Expansion of digital health is also important. These all I would like to do. Thank you so much. Thank you so much, sir.
Amitesh, thank you very much. I think despite the technical limitations, you could convey the message to all the listeners in a concise manner. I know we were short of time, so we delayed.
Yes, sir. That's why I finished it fast.
Yeah, thank you very much. I don't see any comments or chats after the previous presentation. So, but yeah, I think it was very easy on the ears of all the listeners. So good. I think those who are interested in pain medicine specialty got an insight into how, what are the challenges, what are the advantages as well. Now I hand over the floor to Srinivasulu sir and Uma sir for the concluding remarks.
Uma sir?
Sir, unmute, sir.
Sir, unmute, sir. Dr. Umam?
Sir, you have to unmute yourself, sir. Unfortunately, today we are having a lot of technical issues. This generally does not happen.
Okay.
Yes, sir. Now you are unmuted, sir.
Now, yeah.
Yes, sir.
Right. Yeah. So, oh.
Sir, we can hear you.
Yeah. Now you can hear me.
Including remotes.
Yeah. So that was an excellent course on pain. It started with an excellent discourse on pathophysiology of chronic pain by Dr. Vinita, followed by assessment of pain based on various scales, both physical as well as psychological aspects of pain. Then we had a discussion on post-operative pain, how the acute pain transforms itself into a chronic pain. And she described major nerve blocks and the importance of needle anesthesia. And then there was this interesting a discussion on chronic pain conditions by Dr. Jeshnu, and very practical and useful techniques of using ultrasound in diagnosis and pain management in chronic pain by Dr. Sahu, and finally concluded with SWOT analysis of pain medicine specialty, which analyzed the status of pain medicine currently. And all this is possible because of excellent coordinator, Dr. Sri Ganesh. I forgot to mention in the introduction a special and exclusive qualification he has. He did a PhD in pain medicine from the Maastricht University of Netherlands. So, and his nearly 20 years experience resulted in this excellent course. I thank Dr. Sri Ganesh and all the other speakers for making this evening very knowledgeable and helpful learning. Okay, thank you. Thank you all.
Thank you, sir. Thank you. I think we can conclude the session. There was only one question I have replied in the chat box. This was regarding the first speaker, gabapentin or pregabalin dose. And I think there are no any questions that we have left unanswered. So once again, thank you all the speakers and all the listeners for your patience during the technical glitches. And thank you, team ISA leadership, including the president, the secretary, academic chairperson, and the dean and associate dean. Thank you very much.
Is Dr. Bajwa there? Is Dr. Bajwa?
Yeah, I think also sir is there.
Oh, okay.
Yeah, sir.
Yeah,
I
sir.
have listened to every talk.
Okay,
I think
you
the
invite-
last slide did not appear. Somebody has started the live stream actually from their laptop. I think that's what I can diagnose from now. So from next time onwards, sir, I think it's always better before
I think
our
we'll
webinar.
do one trial run.
We will be going for a technical preparation around a day before or maybe 2 days before, so that everything goes in a smooth manner. So anyway, I think 3 hours sitting is a very difficult one, and but the topics discussed were in line, the need of the hour, and this is a specialty, and most importantly, we are going for the DM pain medicine very soon, and that's already in the pipeline. I think we have already represented to the NMC. Let's see the decision when we can start the DM pain medicine. So I think anesthesia specialty has spread its wing to almost everywhere. The DM critical care, DM pain, so DM or different specialties of anesthesia. So I think is one of the most promising branch for anybody who wants to choose a career. Now nobody can say just going to the OT and doing cases like in the GA or spinal. So it's spreading its wings everywhere. Even the emergency medicine, we were the pioneers in emergency medicine too. And moreover, with the upcoming of the College of ISA, things will go more in the positive direction for the academics. And in the conferences also, that in Raipur, we are having the amalgamation of all the super specialty and subspecialties. I think that is a way to go forward in academics and lifting an organization like ISA. So I congratulate Dr. Uma sir, Dr. Srinivas sir, Dr. Kamath, and all the speakers who really spent the time, the precious time. They prepared well, and they showered the wisdom to all our audience. And this class, this webinar will be on the YouTube forever. It will be on the ISA NHQ at YouTube channel. It is after this webinar is over. It can be seen anytime, anywhere, anytime. So that's from my side, and thank you everyone for joining this webinar.
Thank you,
sir. Thank you very much.
Thank you, Dr. Bajwa.
Thank you.
Dr.
Thank you, all the
Ganesh.
speakers.
Yeah.
Thank you very much, Dr. Bajwa. Thank you, all the speakers. I'm very
Yes,
much thankful to you. It's very interesting. Though
Sir,
it's so lengthy.
sir is from USA. Sir is from
Yes, I'm
USA
from
watching.
Tennessee. And
Yeah.
unfortunately, there was some technical issue today.
Yes.
Yeah.
It's an excellent one.
Next time it won't be there, sir. Next time
It
it
will
won't
not
be
be
there.
there, sir. Next time.
It has
Dr.
become
Ashish Devan is also
pain
there,
has
sir.
become a no pain has become a separate specialty. Actually, one should not go to the specific specialist. If one is having pain, they should go directly to the pain specialty instead of going to a neurologist or orthopedic surgeon or any other specialty. That's what I feel. A day has come that a pain specialist can be. I mean, a primary care physician can directly refer to the pain specialist instead of referring to orthopedic or neurologist.
Yeah.
So
Thank you, sir.
I am very proud that I am an anesthesiologist, and now pain has taken over, and very glad actually. Thank you very much, Dr. Bajwa.
Thank you, sir. Dr. Ashish want to say something?
Yeah, thank you. I just want to acknowledge the selection of the topics, which was really very perfect. And more than that, the presentations which were made by everyone were really commendable. I must say that they must have done a lot of hard work, and it's a very beneficiary webinar. Thank you so much, Dr. Bajwa, Dr. Srinivasalu, Shri Ganesh, Dr. Uma sir. It was really a pleasure listening to everyone.
Yeah. Thank you, Dr. Ashish. So, with the permission of everyone, shall we close the class?
Yes, sir. Long live ISA.
Long live ISA.
Thank you.